Good morning and welcome everyone, as Kate said, to ADCES's first ever virtual public policy forum. We are so excited to have such a remarkable, dedicated, and passionate group of diabetes care and education specialists join us for this event today. My name is Kelly Antonori-Lent, ADCES's 2020 president. On behalf of the ADCES Board of Directors, it is my privilege to welcome you to the 2020 Public Policy Forum, and thank you for being here today. I'm thrilled to report that we have 38 states represented today and close to 150 people registered for the event. Thank you all for your ongoing commitment to advocacy. We have an excellent lineup, as Kate said, of speakers featured in today's program. We will hear from Sheila Burke, Tiffany Williams, and Jennifer Suma from Baker Donelson and the Daschle Group, which is a Washington, D.C. based public policy firm. ADCES has been working with Baker Donelson for almost 4 years, and they have been critical in advancing our legislative and regulatory agenda. We also have the honor of hearing from Dr. Gary Puckrin, President and CEO of the National Minority Quality Forum. The NMQF is a research and education organization which is dedicated to ensuring that high-risk racial and ethnic populations and communities receive optimal health care. Dr. Puckrin will discuss the NMQF's U.S. Diabetes Index, which is a critical tool that's designed to reduce the incidence of the disease, as well as improve health outcomes, while encouraging the efficient management of healthcare resources by providing actionable and community-specific information. ADCES's Director of Advocacy, Kate Thomas, who spoke first, will walk us through an overview of ADCES's advocacy activities. She'll also provide a training on current legislation and review how to successfully meet with your legislators. We will round out the day with an update from Jasmine Gonzalvo on what is happening with the National Clinical Care Commission. The National Clinical Care Commission is an entity that has been charged with reviewing all federal policies related to diabetes. As we get into today's program, I wanted to acknowledge the work of ADCES's Advocacy Committee in planning the Public Policy Forum, as well as all of their work throughout the year. The Advocacy Committee, under the leadership of the Chair, Ann Constance, has worked on a number of new initiatives this year, including developing a survey to help state coordinating bodies develop their advocacy priorities, adding new materials to our resource library, recruiting engaging speakers for quarterly advocacy town hall meetings, and elevating the importance of ADCES's advocacy work among our members. I'd like to extend a big thank you to Ann and to the Advocacy Committee. I would also like to extend a special thank you to our sponsors. They help us to make this event possible and for their ongoing support of ADCES. Our sponsors are significant partners in many of our advocacy efforts, and we appreciate their work in advancing important policies related to diabetes. We have added some additional resources provided by our sponsors to the Public Policy Forum on the ADCES's Connect. We will highlight some of these materials in our presentations today. So certainly this year's Public Policy Forum looks different. I've been saying that quite a bit. And yes, we are getting together virtually, but also given the challenge we are all faced in 2020 and the strong advocacy response from our members, a one-day advocacy event did not seem sufficient. And that is why this year's Public Policy Forum is a part of ADCES's Advocacy Week, which kicked off yesterday with an advocacy town hall meeting. I know that many of you were able to participate in the town hall yesterday and heard Teresa Martin discuss the impact of COVID-19 on diabetes and how to use concerning statistics and data to instill a sense of urgency among legislators and even employers in order to improve access to diabetes care and reinforce the role of the diabetes care and education specialist. For those of you who were unable to attend yesterday, Teresa will be recapping some of those key points in this afternoon's legislative training. And as a reminder, ADCES hosts advocacy town hall meetings quarterly. And mark it on your calendar, the next meeting is scheduled for Tuesday, November 17th at 1 p.m., and that is Central Time. You can subscribe to the Advocacy Forum in ADCES Connect to make sure you stay up to date with the latest announcements. Our Advocacy Week will wrap up with virtual Hill Days, which will take place October 5th and 6th. Diabetes care and education specialists will meet with close to 100 legislators by phone. That is like awesome. And they will be able to discuss important issues like expanding access to Diabetes Self-Management Training Act, our legislation, permanently expanding telehealth for Medicare beneficiaries, and other crucial matters related to improving access to diabetes care for all patients with diabetes. For those unable to participate in the formal Hill Days, we ask you to please visit ADCES Legislative Action Center and send a letter to your legislator in support of these important issues. During today's program, we will discuss the many tools and resources that are available to support you in your advocacy efforts. I strongly encourage you to review these tools, especially our new resource guide on how to get involved in advocacy. And try to make it a goal to implement at least one new advocacy activity into your practice. Whether it's sending a letter to your legislator, writing an advocacy blog to your coordinating body, or learning about a new policy or bill. The process of being an advocate is one of constant growth and learning. We hope you leave here today with the tools and confidence you need to change the world. ADCES is so glad, as we have said, you have joined us for this important event, and a special thanks to each and every one of you for all of the important advocacy work you have done on behalf of the specialty, and of course for people with diabetes. We hope this event will help sharpen your advocacy skills and bring our colleagues together in the spirit of collaboration and partnership. So now I would like to turn the mic back over to Kate Thomas, who will begin the ADCES advocacy session and go over activities that have taken place over the last year. Thank you.
Thank you very much, Kelly. And again, welcome everyone. I just recently dropped another line in the chat about accessing the slides. So I'm going to go ahead and get started, and the topic of this part of our presentation is just providing an advocacy overview. And we will cover things in terms of legislative training and how to meet with legislators in the afternoon or the later part of this presentation. But right now, I want to level set. I want to help everybody understand where we are with advocacy and where we're trying to go. So I always like to start off with this slide that defines advocacy, because I think, and something that the Advocacy Committee has worked on is advocacy a term that deters people from getting involved? What does it really mean? So I love that advocacy can be defined as supporting a cause or proposal, or by using education or an argument to do so, because I think that's something that we do almost every day, both in our daily practice and some of our advocacy efforts. If there's anything that you take away from today's Public Policy Forum event, I hope that is there are so many ways to advocate. There is something for everyone. So maybe your comfort level is not necessarily in a legislator meeting, but you are the strongest advocate for the clients you work with who have diabetes. That's another form of advocacy, and there really is something for everyone at all levels. And one of the goals of the forum today is just to provide a framework for understanding some of the national issues and getting involved. So as we're talking today, I want you to think, what does advocacy mean to you? And just warning, I know this group can handle it because you do so beautifully in everything that you do. You are going to be presented with a lot of information today. What we hope you do is listen, learn, think through some things, and then everything is going to be made available to you after today's formal event. Go back, get some ideas. Advocacy doesn't have to be done all today. You can learn from this experience and then take what you've learned and carry that throughout the year. So our objectives for today is to find your path to advocacy, to get a better understanding of some of the issues. Kelly referenced a lot of the materials that we have developed and available for you. There'll be links to everything in the slide deck. We also want you to connect with others as much as you can virtually and apply what you learned. Again, we hope that you take what you learned today and apply it throughout the year, take some type of action, implement something new in your practice as Kelly challenged, and share with others. We hope that you can take this back to your CV and really use this information to advance the advocacy priorities that you hold dear. So what is advocacy at ADCES? And I wanted to take a minute because ADCES has been working on a lot of different initiatives. So here's kind of a high-level overview of what we've been focusing our priorities on. We've been advancing some federal legislation, which I'll discuss. We respond to different federal regulations. We are working on reimbursement and payment issues. There's a lot of state-level initiatives happening that I know many of you involved with your coordinating bodies are involved with. It's all about relationship building, something that's a huge priority for us and something that you all do so well. And then it's really growing that advocacy network. And I cannot speak to this enough. Collaboration and partnerships really help to broaden our reach. And this has been seen, and I'll give some examples throughout these slides, but you as members of ADCES are so powerful in your voice. And so I want to thank all of you for all of the work that you've done and for the work that you continue to do. There's a lot of action happening within the state coordinating bodies and local networking groups. We've got some really great resources to help you if you're interested in working on some of those priorities in your state. We're involved with a number of different coalitions, including the Diabetes Advocacy Alliance, which I'm a co-chair of, and you'll hear from our consultants from Baker Donaldson and the Daschle Group who are also actively involved there. And then with our industry partners, who many of them have joined us today, and you'll hear from them with some great resources. So it's all about empowering the diabetes care and education specialists to advocate in the best way possible. And just a note, I know Kelly touched on it, but I cannot thank the Advocacy Committee enough. As I mentioned, their focus this year has really been making advocacy more accessible for our members. And they've been doing this through a series of quarterly town halls. We had one yesterday with Advocacy Committee Teresa Martin speaking. Our next town hall is on Tuesday, November 17th. This is one not to miss. I'll ping this a few times throughout the talk, but this is going to be focused on access and affordability with some pretty big sharing of information and news. So I hope that you'll join us for that. The Advocacy Committee also posts monthly blogs on the Advocacy Forum on ADCES Connect, and they've developed a bunch of new resources. So there's a new state advocacy priority survey that you can share with your coordinating body. There's a whole document. Once you identify some priorities, how do you get involved with advocacy? There's tips, there's actions you can take, there's suggested state partnerships that you can reach out to. So it's a really valuable, practical document. And then there's a document planning a virtual or in-person state capitol day. Before the pandemic, we were really on a roll with states planning those days. So we hope to get that started again. And then we want to provide opportunities for action. So ADCES advocacy in 2020, what has that looked like? Really, the pandemic response has been a big part of our advocacy efforts, but we have still focused on a number of different areas, which I'll cover in detail. So what happened? What has been ADCES's advocacy response to the pandemic? Since March, we've really been working to help diabetes care and education specialists navigate the pandemic and all of the regulatory and legislative changes. We've been advocating before Congress and CMS, which has resulted in a few temporary changes. Some of the most important are waived clinical indications for continuous glucose monitors and insulin pumps, telehealth expansion in federally qualified health centers, changes in hospital outpatient settings, diabetes self-management training being able to be provided audio only for Medicare beneficiaries. And then as of August, the Medicare changed that DSMT programs, regardless of who was furnishing the service, could now furnish and bill for DSMT telehealth services during the remainder of the public health emergency. And I've dropped a resource in here in case anybody wants to go deeper into some of those changes. But I know many of you have participated on our webinars and have accessed this information. I will say our work is not done. I know that the regulatory changes and legislative changes are one thing. Being able to utilize this in your own practice and get your hospital system or your practice involved and implementing these telehealth policies is another. So we're really trying to work on that, making sure that it's not just a policy change, that it is something meaningful that can be applied. But I want to shout out, when we were talking about who is really part of that advocacy collaboration, it's you as the members. We had over 700 letters sent to CMS from diabetes care and education specialists. Without a doubt, that tipped the scale to get DSMT recognized in some of the CMS communications. I know others that are still working to get their issues addressed. So the fact that DSMT was addressed so early on was hugely instrumental in making those changes. We partnered with other organizations. So as I go through these, I want you to think about maybe different types of partnerships or activations you could have within your state. So you want to engage your state members, you want to find those partners. We had a lot of success working with the pharmacy groups, with the Endocrine Society, and with the Academy of Nutrition and Dietetics. We worked with our coalition partners, so I'm sure there are coalitions that exist in your own states. We had congressional advocates get involved. Senator Jean Shaheen's office sent a letter to CMS and got some other senators to do so as well. I know there were some very active diabetes care and education specialists in New Hampshire that helped get that going. And we also have a close working relationship with that office. So it was wonderful to see all these pieces coming together. We continue to have regular communication with Medicare on some of these issues and comment through the formal rulemaking process. As I said, our work is not done. We still are trying to address the 12 consecutive month requirement for the initial 10 hours of DSMT. And we want to make sure that our members have what they need to implement these policies into practice. And so I mentioned federal legislation as one of our advocacy priorities in 2020. I'm going to briefly go through these things because we are going to be focusing in more detail this afternoon. But many of you are familiar with the Expanding Access to Diabetes Self-Management Training Act. This is a piece of legislation that seeks to remove some of the barriers to diabetes self-management training under the Medicare program. And for those of you whose heads are already spinning from the acronyms, Diabetes Self-Management Training, DSMT, is how Medicare refers to diabetes self-management education and support. They've always got to throw a wrench, keep us on our toes, so that's just the slight differentiation in those two terms. So we're looking for more flexibility. We want to remove some of the cost sharing requirements associated with diabetes self-management training. We want to see more providers being able to refer for this important service, because we know that despite this benefit being around for a long time, utilization is still low. And so I'm going to go walk through this detail by detail this afternoon, but just wanted to get this on everyone's radar as a priority. We're also working on permanent telehealth expansion. So we talked a little bit about some of the temporary telehealth provisions that were expanded during the pandemic. These are only good during the public health emergency, which is currently set to be extended through October 23rd, 2020, though we're likely to see additional extensions. Congress and the administration are considering proposals to make some of these changes final. And so we want to be a part of those conversations. And you'll see some of that in our Hill Day training as well. And if you're not able to make the Hill Day, please visit our Legislative Action Center. We have a letter up there that talks about what some of those priorities are. You can send it right to your member of Congress through our website, and it's very, very easy. We've also been supporting the Connect for Health Act. This predates the pandemic and sort of set the scene for the direction we really needed to see Medicare take in terms of expanding telehealth. I know we've got a lot of folks from Hawaii on the line participating today, so a shout out to the great work of your senator in leading on this. So this is another important bill. It is available on our Legislative Action Center if you want to take a closer look. Last week, we saw the introduction of the Prevent Diabetes Act, and I know the capital letters make it seem a little strange, but it is an acronym. So what this legislation is trying to do is to allow virtual-only suppliers to participate in the Medicare Diabetes Prevention Program. So we know that virtual suppliers haven't been allowed to provide MDPP services, and this legislation would change that. I think there's a real need to improve access, to make use of technology, and to help meet beneficiaries where they are. And some other of our advocacy initiatives, it's not just legislative. ADCES members are talking about reimbursement. This is something that we hear quite often. People are really struggling with keeping their programs open or knowing what codes to use. So ADCES has convened a group of experts to really look into this. We want to look at the current landscape, see what's happening, look at different payment models, how are things changing? And we want to help diabetes care and education specialists maximize reimbursement for their services and really optimize the role and the value of the diabetes care and education specialists within some of these emerging models and within our current healthcare system. So we have the ADCES Practice Management, Coding and Payment Committee. We're identifying coding and payment issues. Most recently, we've been working on the Medicare Physician Fee Schedule proposed rule for 2020. This looks at setting the payment rates and making changes to Medicare policy for the upcoming calendar year. We're trying to develop some new tools and resources, like how do we look at productivity standards for diabetes care and education specialists? How do we address no-show rates and address other important coverage policies? So we're working on some of these issues that our members have really expressed as priorities for us. We're also involved in a number of regulatory and state issues. Many of you were involved in some of the writing of the Healthy People 2030 comments. That has recently launched, so that's an important initiative to help boost the health of all Americans by 2030. We're working on a number of state issues. Certainly we'll cover this, but Medicaid coverage of CGM, of the Diabetes Prevention Program, insulin copay capping legislation, which I understand Vermont is one of the more recent states. I think their governor incorporated insulin copay capping language into their budget, which is expected to become law very soon. Non-medical switching, which is another issue. Medicare policy, which I already addressed, and then some of the work of the National Clinical Care Commission, which you'll hear about later this afternoon. And just a note, you'll be hearing from Jasmine Gonzalvo, who is one of the 12 non-federal members appointed to the National Clinical Care Commission. And she is a diabetes care and education specialist, well known by many of you. And so she's going to give us a run through of what the commission has been working on. And this is an entity that was convened by law to look across all federal programs at diabetes policies and see where they could streamline things, where there were redundancies or where there were gaps. So Jasmine's going to have some exciting preliminary recommendations to share with us today. And then access and affordability is another really important issue. Recently, I was invited, it was last week, to the Connecticut Coordinating Body meeting, state meeting. And they had done one of the state advocacy priority surveys, which I had mentioned earlier. And what they found was that really access to diabetes services, medications, technology, devices, supplies is a huge issue for, obviously we know that, but it's really rising to the top in terms of things that we need to focus on. And so in the pre-read materials, I wanted to make sure you had some of our existing information and materials around access and affordability. The Insulin Cost Savings Resource Guide is an excellent, excellent document that I believe it was prepared by our pharmacy community of interest group, and they've kept it up to date with changing policies. But it provides a link to all the different patient assistance programs and everything that you need to know there. We also have some resources in our sponsor library that I know Lilly and Insulet and some others have dropped some resources there. So I feel like when we're talking about insulin access or overall access and affordability, it's really where are you finding those resources? And so we've tried to build a little resource repository for everybody to refer to. And then speaking to that, one exciting piece of work that we've been involved with, two of our advocacy committee members, Teresa Martin and Mandy Rees, have been working with 12 other groups on this consensus statement on healthcare reform for people with diabetes. And you can see their mission statement in my slide, but really we know the conversation is shifting to healthcare reform, especially around what we're hearing candidates talk about in the election. And so we wanted to make sure that we captured a lot of these principles in a consensus report document. So that is in progress, and I think it's going to speak to the priorities that our members have set in terms of revising and overhauling not just Medicare policy, but Medicaid policies and private payers, value-based models, everything. It's the kitchen sink. So we're hoping to use the development of this resource guide in our work going forward. As I mentioned, we're also working, I know states like California have been working tirelessly on Medicaid coverage for CGM. Others are working on Medicaid coverage for DSMES. There's insulin copay capping legislation, which I referenced. And just another acknowledgement that diabetes care and education specialists are working across the country on the state level on access and affordability issues. And for anybody who listened to our most recent podcast with Ann Constance, she had some great tips on making sure that you are really leveraging all of the partners and stakeholders within your state to do so. So check out the Huddle, ADCES's podcast, and look for Ann's podcast because it's a really great one. Not just medications we're talking about, but also diabetes technology. As I mentioned, we've seen some temporary flexibilities around CGM and insulin pumps. We're also working on that 4 times per day testing requirement under Medicare. I know this has been especially difficult in having access to supplies as well, because some of the pharmacies aren't able to meet supplies that go beyond the 3 times per day or 4 times per day requirements. So it's been challenging. And then again, in covering all of these topics, I hope that you're getting some ideas just to see what's out there and to maybe take some notes for your state of things that you might be interested in working on. And so I also wanted to flag, I know our partners with Lilly and Xeris are on the line. There are new glucagon delivery options available. We all know that these are important advancements for people with diabetes and should be made available, especially through insurers, to meet people where they are based on that person's preference. These new delivery options for glucagon are life-saving treatments for severe hypoglycemia. When we're talking about a pandemic, we want to do everything possible, even not during a pandemic, to keep people out of emergency rooms without having to be hospitalized. These are critical things. And I think with these new glucagon options, you're not having the complexity of the traditional glucagon kits. And so when you're talking about having untrained individuals providing glucagon to people, we're talking about parents, teachers, roommates. So this has been a huge advancement in making glucagon more accessible for people to deliver in an emergency situation. So part of the advocacy is advocating for insurance coverage for all glucagon delivery methods. And I can tell you, I know Xeris is working on this and Lilly as well, but we're also having to keep up with some of the state laws in addition to some of the insurance changes. Just this morning, I was on a thread talking about legislation in in the state of New York that would allow the Department of Education to have nurses train school personnel on emergency administration of all glucagon products, not just injectable glucagon products. There has to be a change in the law to do that. And so if you're interested in working on this type of legislation in your state, it's going to be important that you kind of dig in and look at the need for either a legislative changing through law or regulatory approach. And if you need any help with that, please get in touch with me and we can get you some more information. I also wanted to note some of the work that INSLET is doing to ensure that people with diabetes have access to diabetes supplies through the pharmacy. They've been working very hard to accommodate CMS's ruling that the Omnipod should be covered under Part D. And I think they've been very much focused on streamlining the business so everything is through one channel, which breeds efficiency, cost effectiveness, and a better customer experience. And they've had some great results. They've been able to gain pharmacy access for over 200 million of the covered lives in the United States. But we are seeing some challenges with some plans, some private insurance plans and Medicaid programs not yet having adopted the Omnipod through the pharmacy benefit, and even some state Medicaid plans preventing access through the pharmacy benefit. And I've listed some examples here. I know INSLET and others are happy to connect if you want to do some advocacy on this issue, and they've provided a great call to action. So when you're talking to your legislators, I think it's important to remember that we're advocating for access for all diabetes tools so people can manage their diabetes. INSLET has a great site, Advocacy for Access. I encourage you to visit our sponsor library and check that out because there are so many resources in there. It helps you tell your story, which is something that we're going to really focus on. I think that gives a lot of meaning to what we're doing. And so if you have any questions about Medicaid or want to get involved in your state, I have contact information for Michelle Torrey from INSLET who can help you get connected. And then another important issue that I want to talk about, which is coming up very quickly, is around open enrollment. And many of you may recall back in March, and then there was some more hype around, I think it was June, CMS announced this Part D senior savings model for 2021. And what this would do, it would limit the cost of insulin for participating individuals to a maximum of $35 for a 30-day supply. Keyword, you'll see this word bolded, participating. So a Medicare beneficiary with Part D has to enroll and specifically opt into one of these models within the senior savings program. And I don't know about you, but I know every time it's time for open enrollment, it's always a challenge to understand your plan and choose the right plan. So we really want to break that down and provide some resources as you're talking to your clients. The program takes effect on January 1st, but beneficiaries must act now. And I pulled some of this information from the ADA's webpage, which I've linked down below. Before October 15th, we're encouraging people to check their Part D prescription plan and see what types of insulin you're prescribed. And then when open enrollment for these Medicare Part D programs begins on October 15th, you want to review your current plan to see if you can elect to participate. You may need to switch plans in order to access this benefit, and you must do so before the open enrollment period ends on December 7th. You can review all of the plans using the Medicare Plan Finder, and that will help you find the right plan and compare. And this is a Part D benefit only, so we're not talking about anything under Part B, unfortunately. But it is an important step forward, but it involves taking action. So beneficiaries have to take action on this, and we want to equip the diabetes care and education specialists to know how to direct them or make them aware of this important program. To help, Lilly has launched Insulin Affordability, Learn, Act, and Share. This is a great way to learn about some of the affordability options. You can go to this site by accessing insulinaffordability.com or calling the Lilly Diabetes Solution Center, which I will link to in a later slide. Please share this information. You must enroll to participate, and for many other plans as well too. Everybody needs to take action on this, not just Medicare beneficiaries, so please visit the site. It's very user-friendly. You can put in your zip code to help you find your plan and those that are offering Lilly insulins. Other manufacturers have information as well, so I would encourage you to check that out. And then again, resources are in our sponsor library. So obviously access and affordability is hugely important, and I think that ties into some of our work in supporting health equity through policy. So I wanted to talk through a few key things that we've been working on in this very important area. As I mentioned, I'm the co-chair of the Diabetes Advocacy Alliance, which is a group of 25 individual groups that come together to work on shared diabetes policy. We're using health equity. We developed this health equity work group, and we're using health equity as the lens through which we identify our advocacy priorities. We're developing a principles document, and we're really trying to expand our membership and open up our conversations to new voices and perspectives to help us identify policies that we can support that can promote health equity. Jasmine Gonzalvo from the National Clinical Care Commission will also be talking about some of the Commission's efforts to support health equity and to really focus on some of those social determinants of health like food security and transportation, building healthy communities. Leslie Kolb, our Chief Science and Practice Officer, was chair and involved with one of the groups under the Health Equity Collaborative, which was formed by Medicare's Office of Minority Health. And they've developed some recommendations that I'm hoping that we can put into practice, a lot of them around improving access to both the diabetes prevention program and to diabetes self-management education and support. And they've also prioritized addressing food security, which is hugely important. And then we've also focused on many of these access issues, which I've discussed, but they continue to be important priorities for us as we really put our focus on health equity. And of course, a shout out to ADA's new Health Equity Now initiative, which has some really great action steps. And then kind of rounding us out, I want to, certainly timely following last night's presidential debate, but certainly all eyes are turned, and you'll hear from our folks at Baker Donaldson more on this, but all eyes are turned to the November 3rd election. We're just a few short days away. So ADCES has developed an election guide document to help you engage with those running for elected office. It could be president, federal level, state level, local level. And the impetus for this document came from one of our earlier town hall meetings where diabetes care and education specialists were asking for some bipartisan information or a framework by which they could drown out some of the political noise and really try to find out what are the policies out there and what policies really help to support people with diabetes. This is a way, this document can help you engage in the political process, talk to candidates, find out information, and do all sorts of important work. This is available, I've linked it here, but also on our website, diabeteseducator.org/advocacy, and this podcast will be coming soon. We're gonna go into more detail. And then just a few notes about what this contains. We have some core principles that we've identified. Many of the things that I've talked about today are contained in this document as well. We want to encourage coverage of a broad set of essential health services required by people with diabetes, support access to innovative technologies that we've covered all of these in detail, as I mentioned, and promote programs that reduce cost, improve care, and foster innovation. And really, we want all people with diabetes to have access to whatever they need to successfully manage their diabetes. And then a few key provisions, really, and this is something, these are in our election guide, but they certainly can be incorporated into the conversations you're having with your legislators. But we want to preserve the elimination of any pre-existing condition exclusion. This is so important. Feel free to raise this in your congressional meetings. You can ask questions of your legislators, but we really want to make sure that pre-existing conditions are protected. We want to prioritize prevention and screening, and we want to prohibit discrimination in plan design. And so I have a few minutes to take questions before we turn it over to our next speaker. And what I'm going to do is I go through the questions in the chat. I'm going to play this quick video about the Lilly Diabetes Solutions Center and jump back on to answer any questions.
So an average call at the Solutions Center. So an average call at the Solutions Center. You're usually talking to an individual who feels defeated.
When they call us and we answer the phone and we say, "Thank you for calling the Lilly Diabetes Solutions Center. My name is Julia. How can I help you today?" That's huge for them. It's not just "thank you for calling," it's "how can we help you?"
They've been told there may not be help so many times that they're kind of surprised when they call us, and we are able to potentially offer them a solution to make it more affordable for them.
As a person with a registered nursing background and having the
Is it just me or are we?
Hi, I'm back. Can you all hear me?
Yes.
Okay, sorry about that. I think the video might have disrupted, but is everybody back on? Okay, so we are going to take a quick 5-minute break. I will go through any questions. I'm sorry about the technical difficulties, but let's take a quick 5-minute break. We'll be back online in 5 minutes, 11:20 Central Time, and then we will hear from our partners at Baker Donaldson. So please take 5, and I'll go through anything in the chat and anything else. Okay, everyone, we're back. Thank you for bearing with us through the technical issue. I've posted a link to the video for the Lilly Diabetes Solutions Center and also to the Lilly Diabetes Solutions Center itself in the chat. Thank you for those questions. And without further ado, I'm going to turn it over to an excellent group of individuals that I'm so happy to have here today. We have Sheila Burke and Jennifer Suma from Baker Donaldson and Tiffany Williams from the Daschle Group. These are ADCES consultants, but they are much more than that. They are boots on the ground in terms of federal policy. They are meeting with congressional offices, they're meeting with the administration, and they have been just absolutely instrumental in advancing our policies. We were just emailing this morning about Senate strategies, so they never stop. They are such excellent supporters, and I'm so excited to hear that you get to hear from them today. So without further ado, I will turn it over to Sheila.
Great. Thank you so much, Kate. And Kate, if you go ahead and advance to the agenda slide. Great, thank you. Let me first begin by thanking Kate for allowing us to be with you today, and really thank both Kelly and Kate for including us in the very important work that you're doing. We have so appreciated the opportunity over the last 4 years to work with all of you and to work with them in the extraordinary work they're doing to put this issue out front and continue their efforts to essentially make it known and address the issues that have existed. I also want to begin by underscoring the point that both Kelly and Kate made, and that's the importance of your engagement. We can do as much as we can do in terms of helping to develop the relationships and responding to questions and helping Kate in preparing materials. But at the end of the day, what really matters is your relationships and your contacts with your members. And so I cannot underscore enough how important that outreach is, your participation in days here in Washington, virtual though they may be, but also at the local level in terms of engagement with your state and local officials, because this issue really is one that plays out at every possible level. And every possible level of government has an impact on what in fact can be done and how we in fact can support this community in terms of access to services, in terms of research. And so again, I underscore the importance, particularly this year, which we'll touch on. The things we're going to talk on in our very brief time with you today, and all three of us will have the opportunity to talk with you, are really what's happening, the administration's priorities in this time that's available, what may occur in a lame duck session, what the election portends for us, and considerations for 2021, depending on what happens in terms of the outlook. Next slide, please. What you see here is a calendar, and the calendar really underscores the very little amount of time that remains during this session before the election. It could change, of course, particularly in the Senate with the court nomination, with hearings beginning on October the 12th. The initial schedule had both the House and Senate out by the 12th, but in fact the Senate, at least the committee, will be meeting, and then presumably their desire to confirm the Supreme Court nomination before the election would suggest they'll be back again for a full vote in the Senate. But there are critical issues that need to be considered in the time that is remaining in both bodies. Certainly among those is the continuing resolution, which contains a number of important provisions. Certainly the Special Diabetes Program grant funding, the grant funding for the Indian Health Service as well relating to diabetes is included in that continuing resolution. The Senate is scheduled to vote on that today. Our expectation is that it will succeed, and we will have in place appropriations at least through essentially the 11th of December. And then, of course, is the open question as to what happens going forward. COVID relief, there is a new conversation occurring between the White House and the Senate and the House Democrats and Republicans about what another bill might portend. The Democrats have put on the table a $2.2 trillion initiative. The White House seems to be working around $1.6 trillion. So fairly deep divisions between the White House and the Democrats as to what that might contain. At heart, there are changes with respect to suggested support for individual small businesses, for individuals themselves, for vaccine preparation, for the airline industry, for example, which is in the latest Democratic proposal. But essentially, the question will be whether they can complete that work and come to some agreement before they actually break for the election. There are critical issues that have been raised in terms of the availability of resources at the state and local level, and the need for additional funding to support schools and other programs, certainly with respect to unemployment and benefits provided to individuals, all at issue. On the Republican side in the Senate, issues with respect to liability. And again, the question will be whether they can come to resolution and whether or not they can complete that in the relatively short period of time remaining. Again, as I noted, the Supreme Court battle has begun. Meetings on the Hill are taking place. At issue, I believe, for most of the Democrats in terms of looking at this nomination will be issues around the ACA and the position of the nominee on that question. Also questions with respect to reproductive rights. The hearings will certainly highlight areas where they will probe her prior decisions, her writings, and essentially trying to determine where she in fact might come down on discussions that would follow. As you are, I'm sure, aware, the ACA comes back before the court in October, and questions as to whether or not, in fact, the efforts on the part of a number of states to essentially take down the entire statute will be pending. So a great deal that really is dependent upon that decision, but it is one that is likely to occur in October prior to the election. Now, let me turn it over, if I might, for a moment to Jen Suma, who can talk a little bit about what the priorities are for the administration in the remaining time available prior to the election and then potentially going forward. Jen?
Great. And if you could advance to the next slide, that'd be great. So as Sheila mentioned, her administrative priorities has already mentioned about the Supreme Court. So hearings are going to begin the week of October 12th. The committee is planning to vote by October 22nd and hopefully confirm Amy Coney Barrett by election. Besides just the ACA being an important issue before the court, is if there is a close election. So if there's, with the mail-in ballots or whatever, it's likely that this decision of the presidency may even go before the Supreme Court. So that's another reason why the Republicans are very anxious to have Barrett confirmed before the election. The next thing is also the COVID vaccine. So it's unlikely to have the vaccine before the November election, even though there was lots of push in the beginning to make it to that date. The HHS did announce yesterday that it was more likely to be the first part of next year. So as of yesterday, we have actually 43 vaccines in human trials. 93 are in preclinical animal trials, with 11 being in the phase 3 stage. So no approvals, but everybody's moving closer. So we're likely to have a handful of vaccines approved sometime early next year. Another thing that is important to the administration is drug pricing. There was a executive order in July that FQHCs are to pass along the discounts on insulin and from drug companies to low-income Americans. Kate also mentioned the $35 Part D and enrollment beginning October 15th. The EO also allows for the safe legal importation of prescription drugs from Canada. And it's also going to prohibit the secret deals between the drug manufacturers and the pharmaceutical benefit managers. So ensuring that patients get discounts available to them at the pharmacy counter. Another thing that, and I don't know if folks remember back to when Part D was first introduced in 2004, the big discussion was about the safety of importation or reimportation of drugs from other countries. But this EO is actually going to allow for reimportation, but also it's going to ensure that the U.S. pays the lowest price available among the economically advantaged countries for drugs, for Part B drugs. Kate did a good job at discussing telehealth. A lot of the administration has signaled, of course, through the public health emergency. It does expand a lot of the types of services that could be provided by telehealth. There's the administration, though, has signaled that both they would like to have some sort of extension of telehealth beyond the public health emergency. So there's legislation that folks are working on to that end. I would say that the ADCES has a great fact sheet on their website if you want to know more about some of the telehealth provisions that are directly related to the diabetes care. And also that the one thing that the administration has done, there's been a bunch of executive orders, one recently in September that talks about pre-existing conditions. So I know that a big election talking point is that if the ACA gets overturned, or that the concern about pre-existing conditions, but they put out a executive order in September to highlight that. It directs HHS to work with Congress on legislation also that tackles surprise billing. And if it's not done by January 1st, that HHS can take administrative action to solidify some of the things within the executive order, like surprise billing. So I think that Kate has did a good job at highlighting some of the things with the insulin, the drug provisions, as well as telemedicine. So I would definitely say take a look at the website that ADCES has, the fact sheets there that can give you more information there. And I will turn it over back to Sheila.
Great, thanks so much, Jen. Really tremendously helpful. Jen has tremendous experience having served in an administration in the past at HHS, but also served on Capitol Hill on the Finance Committee. So Jen is a remarkable resource in helping us understand the regulatory issues as well as legislative. Very quickly on the lame duck, it will occur arguably after the election. For what period of time is not yet set. Among the things that will be most critical to consider during that period of time. And of course, it will be influenced without a doubt, notwithstanding the fact that it's the same Congress, by the outcome of the elections. Issues like appropriations, for example, the continuing resolution is currently expiring December 11th. How long the next act will take, whether they can actually complete action on all 12 appropriations bills, unlikely. And so there is likely to be a continuing resolution into next year. How long that will go will depend in large part on the outcome of the election. Were there to be a change in administrations, the Democrats are likely to ask for a longer transition period. Were it to be the Trump administration, they're likely to try and get into it very quickly early in the new year. Healthcare extenders, again, a number of these provisions that were included that expire as well are going to be very important. Reductions in Medicaid hospital payments, DSH payments for disproportionate share, the CARES Act, paycheck protection provisions, a number of tax provisions, including healthcare coverage credit, the increased medical expense deduction. All of these things are likely to be things that come up during the course of the lame duck. And of course, it's unclear if any other issue might occur that might lend themselves to essentially legislative action. The vaccine issue, one that Jen has raised, if they in fact haven't yet resolved the CARES Act issue, questions about funding that it might be necessary, again, for the opening of schools, the opening of small businesses. All of those things could take a great deal of time. But again, the outcome of the election may be unknown. To Jen's point, the court may ultimately get involved. And so, again, there's a great deal of uncertainty as to the timing and as to what measures and what issues will, in fact, confront the Congress when they return from essentially the election. Next slide, please. We could clearly, and go ahead and move to the next slide. Thank you, Kate. We could clearly spend the rest of the day talking about the election. So this is a very quick touch on what to expect and what to watch. 116th Congress, this is the second session of that Congress. Essentially, as you see here, what the current division is. As you know, during an election cycle, about a third of the Senate is up for re-election and the entirety of the House. And so you've got lots of play and lots of attention to essentially what this looks like. So this gives you what it looks like today with essentially the Republicans controlling the Senate and the Democrats controlling the House. So the issue will be whether or not either of those is likely to flip. Next slide, please. What you see here is a projection. The Cook Political Report is Charlie Cook, who is a known pollster and often referred to in looking projections at what might or might not occur. What you'll see here is because of the cycle, there are more Republicans up in this session as is compared to prior sessions where there were more Democrats. There are more Republicans at risk. Number of retirees. This gives you a distribution of what it possibly looks like in terms of which direction people are likely to go. As is noted by Charlie Cook, you'd need at least a gain of 4 seats to flip the Senate to the control of the Democrats. And you see here what some of the risks, the toss-up states, McSally in Arizona, Gardner in Colorado, Collins in Maine, Tillis in North Carolina, and some leaning but not certain GOP. There are solid Democrats. Most of the Democrats are in fairly good shape, but there's always a surprise. As you know, at the end of the day, all politics is local, but this gives you an idea of where the races are taking place, but also where they are exposed. And what never one knows is what the impact of the presidential race will have, either on turnout or on the down ticket response. So again, it gives you an idea, but again, the Democrats would have to pick up 4 seats to flip in terms of taking control. Next slide. Now the following set of slides, next slide, please. The following set of slides, I'm not going to go through individually, but it gives you an opportunity to look across essentially the current House base. Again, there is the Democrats would have to lose essentially 21, or the Republicans pick up 21 seats to flip. And you'll see over the next few slides, and Kate, go ahead and go through them, where essentially there are targets. Trump districts that Democrats won, for example, in 2018, and where those might be vulnerable. Areas where Clinton essentially, the Democrats flipped in 2018. So again, each of these is their own battle. And each of these, again, politics is remarkably local, but it gives you a sense of the complexity. It is currently not projected that the House would flip. The Senate is uncertain. There are enough people close to the line that there is a possibility there, but it is at least currently suggested it is unlikely to see that flip in the House. But again, we can be surprised. We've been surprised before. Next slide, please. Now, very quickly, and then I'll turn to Tiffany, one has to begin to look at what the post-election scenarios might be. In this case, we reflect on both the sort of a status quo, were Trump to retain the White House, or if, in fact, the House were to flip. The most critical note is essentially in a case of a status quo, you can expect wholesale changes at the cabinet level, not unusual in a second term for a president. Although this president seems to have gone through a lot of cabinet officials already. There'll be continued focus on the court appointments. He noted that in the debate last night. They've achieved a remarkable result in 300 postings to the court. 3 Supreme Court nominees. That will continue to be an issue. Certainly continued attention on lessening the regulations of a number of programs, including the Medicare Advantage program. Continued efforts at entitlement reform, particular focus on Medicaid, where they've tried to pour more to the states, the drug pricing issues that Jen touched on, expanding U.S. manufacturing, certainly across the board, certainly in drugs, but across the board, and then obviously continued immigration reform. And then again, depending on where we are on the virus, would have an impact on what in fact they would choose to do. If the House were to flip, and essentially you would have both bodies controlled by Democrats, both the House and the Senate, a different scenario for a new Trump administration, where no doubt if they were to pick up the House and have both the House and Senate, they'd certainly go back after the ACA, certainly after entitlement reforms, particularly given some of the issues with respect to debt. And the amount of debt that we've incurred over the last couple of years in an effort to take a lot of that out of the domestic programs. Drug pricing reform, as Jen pointed out, drug and price transparency has been a theme that the administration has talked about with respect to drugs, hospital prices, physician prices, and so forth. So a lot of continued effort and more pressure to essentially put forward their agenda in terms of regulatory reform. Let me now, if I might, turn it over to Tiffany to talk about what the case would be in a Biden election.
Thanks, Sheila, and thanks, ADCES, for having us. So as Sheila mentioned, I'm going to be talking about what a Biden White House may look like. I think we expect likely of one of two scenarios. Either Republicans would keep the Senate or the Senate would flip. Taking the current Congress first, where Republicans would retain the Senate, it would be clear that under a Biden administration, the administration would likely be doing most of the work. We would essentially have what we have today, which is a bit of political partisan gridlock in Congress. Short of legislation being truly bipartisan, we would likely have only administration action and very much a lot of congressional inaction. To that end, with respect to healthcare, we expect the Biden administration to focus on preserving and strengthening the ACA. With just control of the White House, we would expect that maybe to look like undoing Trump guidance and policies that have been put into place under this current administration, and potentially some executive orders. But again, not much would likely happen from a legislative perspective if the Senate was to retain. If Republicans were to retain the Senate. With respect to drug pricing, that is one of few bipartisan issues. Both Sheila and Jen have talked about it from a Republican perspective. While Democrats have typically talked about addressing drug prices from the perspective of addressing the actual price of the drug, whereas Republicans have talked about it in the context of mostly rebates and discounts. Nonetheless, we probably would see some action in the drug pricing space. I expect the Biden administration may want to work with drug companies in trying to bring prices down. They may take the approach of executive orders, or there could be some bipartisan legislation similar to what we've already seen in the Senate from the Senate Finance Committee or from the Help Committee, addressing some low-hanging fruit, such as capping out-of-pocket costs for seniors. In terms of COVID response and pandemic preparedness, I think it's pretty clear that Democrats have called into question how the administration has handled the COVID pandemic from day one. So I think we'll see a very different approach to how that is handled. Biden and Harris have already talked about expanding access to testing through a national testing campaign. They've talked about standing up a national public health surveillance program for contact tracing and ramping up federal agency guidelines. So I think we'll see a lot of administration activity there. Beyond COVID-19, though, we'll also see some public health infrastructure changes. Without the Congress, we'll likely see more so just a redirecting of funding potentially to CDC and to HRSA to kind of rev up the areas around public health and public health workforce. Again, another priority for a potential next administration would be racial and ethnic inequities and how we handle dealing with health disparities, particularly in healthcare. So we expect the HHS to kind of be looking at their policies and thinking about their guidance and their rulemaking through the lens of addressing racial and ethnic inequities. Another bipartisan issue is surprise billing. That's been a big conversation throughout this Congress, and and as Jen mentioned, the administration has recently attempted to try and address it as well. If it's not addressed before the end of this year, I expect the administration will again try to work with Congress to get that fixed. And lastly, telehealth, also another bipartisan issue. It's one that's been tricky because of concerns related to cost and program integrity. But nonetheless, I think the administration will want to expand upon where they have the authority to do so, the waivers that they've put in place under Medicare during this public health emergency. So if the Senate flips, it's a game changer. Biden will be able to do essentially whatever he wants. He'll have a Democratic Senate and a Democratic Congress. As Sheila noted, the Senate is very much a toss-up, so it's a very real possibility. And there's definitely some overlap in terms of what will happen both with a Senate flip and a Senate staying Republican. But again, it's a game changer if we have a Democratic administration in Congress. Starting just again with respect to healthcare coverage and access. On the campaign trail, Medicare for All was a popular topic among most of the Democratic candidates. Biden stood out with his approach of a Medicare-like public option instead. I know a lot of folks are interested in what that looks like and whether we're going to go full steam ahead public option. My guess is that we won't. Democrats are very divided in the Congress as to what universal coverage really looks like and how we get there. And I don't expect that Biden's going to want to divide the caucus on day one. So I think the focus will be strengthening the ACA. And we might see that in a few different ways through various fixes that the House Democrats have already passed and that Senate Democrats have also looked at as well. And so that can take a number of different ways. That can include increasing premium tax credits, increasing the eligibility for tax credits by removing the 400% federal poverty level cap, incentivizing Medicaid expansion in states that have not already expanded, and again, reversing some of the president's current policies around short-term limited duration plans and some of the 1332 state waiver guidance. Drug pricing, again, will still be a priority, particularly if we have a Democratic Congress and White House. But there will be more that they can do on the legislative level. So we might eventually see the allowance of the secretary to negotiate Medicare prices. We might see more in the drug importation space, greater allowance of generic drugs to the market, more limits on launch prices and efforts to tag prices to other countries. So again, there'll be a lot to do in the drug pricing space. Something to add something that's new on this side of the column is Medicaid. A Biden-Harris administration is likely to work with Congress to think about how best to expand Medicaid across the country. And that might also include increasing FMAP for various states and also expanding Medicaid coverage, quite frankly. Black maternal health and morbidity has been a very big issue this year, and I expect there might be some changes with respect to, on the federal level, with respect to what Medicaid can cover when it comes to maternal mortality and morbidity. Next, I would say that Democratic administration and Congress would also likely and are expected to double funding for community health centers. That's been a big priority for Democrats. There will be a renewed focus on public health infrastructure and workforce. Biden has also spoken about Medicare access and potentially bringing down the age from 65 to 60. Again, addressing racial disparities and ethnic disparities in healthcare. And lastly, again, surprise billing and telehealth. I would say that with respect to telehealth in particular, with a Democratic Congress, we might actually see some removal of the statutory barriers to telehealth with respect to originating and geographic site restrictions. So a lot can happen if we have a full flip, but I guess we'll find out soon. Next slide, Kate. So as many of you know, we've been working with the House and the Senate to advance the Expanding Access to DSMT Act that Kate mentioned briefly earlier. And Kate has really been critical to our efforts in both bodies. And I know Kate will be discussing the bill in greater detail later. So for now, I just wanted to give a quick update on where we are right now and a plan for a potential new Congress. So just briefly, earlier this year, we convened the 4 co-sponsors of our legislation, Senators Shaheen and Collins and Representatives DeGette and Reed. We worked with them to respond to questions from CMS, which we call CMS TA or technical assistance. Through a comprehensive process working as a group, we addressed those questions from CMS and worked with Senator Shaheen's office to update the bill, which was provided to Legislative Council. Since then, we've been working with Senator Shaheen and Collins and committee staff on the Senate Finance side to secure a score from the Congressional Budget Office. As you guys may know, a score is really important because it tells us whether a bill is going to cost the government money or whether it's going to save the government money. As you can imagine, it's much easier to pass a bill that saves the government money. So a score is critical to being attached to a larger another moving vehicle. By vehicle, I guess I would say, there's the Christmas tree approach, which often happens at the end of the year where members pile on their priorities to one bill and it gets shoved out the door. And then there's also the possibility of a standalone healthcare package that Sheila alluded to during a lame duck session. Very TBD as to whether we have a standalone healthcare package, but it's a possibility and it's something that we have been preparing for throughout the year. But given our short legislative calendar and COVID relief package and the spending packages, that might be a bridge too far for this year. So in the meantime, we've been working with CADE and the Diabetes Advocacy Alliance to secure greater bipartisan support, particularly from Senate Republicans on committees of jurisdiction, so that we can push to get a score. In terms of for next year, I think the good news is that we are in a very good position to move something for next year, and we're very well suited to advance it in the next Congress. To that end, if we don't have a vehicle for this year, we would reintroduce the bill with our current co-sponsors and potentially others. We would continue to build bipartisan support in the House and the Senate, but particularly among Republicans, especially if we continue to have a split Congress. We would continue to do much of what we're doing now to try and secure a CBO score. And we would explore ways in which to amplify the importance of DSMT, similar to what you guys are doing when you go on the Hill, virtually when you speak to members on the Hill about the DSMT bill and all of your asks that Kate was referring to. It's important to get policymakers to hear about the importance of DSMT, either through your fly-ins, through hearings, through briefings, et cetera. So we'll work to amplify that importance to make it easier for them to pass our bill in the next session. And then again, looking to attach it to a viable vehicle during the 117th Congress. And with that, we have some time, hopefully, for a few questions. So thank you again.
Back to you, Kate.
Thank you very much for that excellent overview. While you were talking, I was getting a series of emails saying, this is great, this is such excellent information. I know we're running a little bit tight on time. If anybody has any questions, go ahead and drop it into the question and answer, and we'll try to follow up. But I did want to make a note and ask you one last question. As we're going into our congressional meetings next week, is there any tip that you would offer based on some of your conversations on the Hill? Anything that you think legislators are going to want to hear from healthcare providers?
Let me ask Jen and Tiffany, who spend most of their time on the Hill. My initial reaction is the fact that they are providers matters enormously. They like hearing from people who are actually involved in providing services, putting a real face on an issue rather than simply statistics. Makes a huge difference. The extent to which you're from that member's state or general, congressional district, they want to hear the story about what's happening in their community and why this matters. So underscoring the sort of personal connection, I think, is enormously important. But Jen, Tiffany, anything you would suggest?
I guess the only other thing I would add is to talk about, and I'm sure your members will do this, thinking about the patients and talking about the patient story, and making it relatable to the members. Many of us, and members included, have some touch and personal connection to diabetes. So trying to make it as personal as possible to them is hugely impactful.
Yeah, and I'll just agree, second what Tiffany and Sheila said.
Great.
And I would underscore the importance of knowing whose office you're going into. And if you were from that area, sort of get a sense of, what you know about them. And I know Kate's done a tremendous job, but sort of know in advance sort of what you're walking into. Diana DeGette, is somebody that obviously knows this issue, has a child facing this issue, but the extent to which you have any personal sense of the member certainly helps.
Absolutely. All excellent points and things that we'll be covering in detail this afternoon. And in the interest of time, I'm going to go ahead and probably switch to chat to answer some of the questions, but I wanted to thank you for such an excellent presentation today. The fact that you provide such comprehensive information about what's going on in Washington, not to mention all the work that you do on behalf of diabetes care and education specialists and people with diabetes every day. We just thank you so much for your expertise and all that you do. And I'd like to now transition over to our presentation from Dr. Gary Puckrin. And thank you again to Jennifer, Sheila, and Tiffany.
Thank you.
Hi, Dr. Puckrin. We're so happy to have you here. I've got your slides queued up. Do you want to advance them or would you like me to?
You can advance them, that'd be fine.
Okay, perfect. And I know Kelly did a brief introduction before we got started, but I think Dr. Puckrin is one of the most sought after men in Washington right now. He's the man with all the data. So I know he's given quite a few talks. He's the president and CEO of the National Minority Quality Forum, and he is going to present some excellent information here today. So I'll turn it over to you.
Well, thank you so much. I'm not going to talk a little bit about why I think of seniors as the vanguard, but as I move through my slides, I think you'll get the understanding. Next slide. So I want to talk about a social contract. A lot of times when we start talking about healthcare, we do it in a tactical way, not really understanding how all of those pieces fit together as they relate to our social contract. And then I want to talk to you about the National Minority Quality Forum. And then I want to take you into a deeper dive into Medicare fee-for-service and the promise of Medicare Advantage. So next slide. So this is really a quick quote by former Justice Sandra Day O'Connor. She was lamenting the fact that we don't teach civic education in schools anymore. And it really has real implications, even in healthcare, because our whole country is built on a social contract. And it's really important that each generation understand that contract. And certainly as we go to build legislation and practices, we need to understand that. Next slide. So the social contract really is embodied in that Declaration of Independence, the preservation of life, liberty, and the pursuit of happiness. So we all come together towards those aims. And if you look at the final draft of the Declaration of Independence, it really sets out the prime directive of our society. Government was organized to conserve life that was equal, inherent, and inalienable to each individual. Conservation of life is a collective act. It's part of our social contract. And when I think about that in terms of our healthcare system, I think about it in terms of reducing patient risk. When patients go to the hospital or the emergency room, they don't expect that the healthcare system is going to elevate its risk, that at the end of the day, the healthcare system is not reducing their risk. And I'm going to walk you through the data on diabetes to show, well, that's not what's happening. We're actually elevating patient risk. And I'm going to take a look at the Medicare program. Next slide. So quickly, a little bit about the National Minority Quality Forum. We are a research and education organization based here in Washington, D.C., and our mission is really to reduce patient risk by assuring optimal care for every patient. Next slide. And so what we focused on is data collection. We've built a database of over 5 billion patient records. We collect data on about 130 million lives per year across about 72,000 diseases, including diabetes. And we can look at the prevalence and cost and outcomes by demographic subgroup. Lowest geography is zip code, but we can aggregate up to state, congressional district, et cetera. Next slide. So I want to talk to you about what we see as the Medicare acute care model. So what we did is we took every Medicare beneficiary and we aggregated them into 5 buckets based on how much Medicare spent on them in 1 year, except for prescription drugs, because prescription drugs, depending on the formulary and all kinds of things, the cost could differ. But here we're talking about ambulatory care, emergency room, hospitals, skilled nursing home, et cetera, costs. So we've got 1%, we call those crisis consumers. And mind you, this slide was done back in 2000, and I'll show you what it looks like today. The average cost back then was about $134,000 per crisis consumer, and they represented about 1% of all Medicare beneficiaries. And down at the bottom, we call them low consumers. They represent about 67% of all Medicare beneficiaries. And back in 2000, we were spending about $339 a year on their care. And you can see that most of the cost of Medicare is in going to the hospital. And that's why we call it the acute care model, because at least in Medicare fee-for-service, we don't do a lot to intervene in an organized way and reduce the risk of hospitalization for people. Next slide. And the model is the same thing in diabetes, except in diabetes, 3% of those being treated for diabetes in the Medicare population are crisis consumers. In fact, 50% of all the crisis consumers in the Medicare program have an underlying condition of diabetes. And then down at the bottom, those low consumers, they're low consumers because of the way in which their care has been reimbursed for, but that doesn't mean they don't have asthma and COPD and chronic heart failure and kidney disease. It's just that in that particular year, the program spent less on their care. And we've done this, we've taken the guidelines of the ADA guidelines and matched them to CMS's reimbursement schedule. And you can see that these low consumers are not getting standard of care by the very reimbursements that are made for their care. And again, you can see the cost is really being driven by hospitalization. Next slide. So this is the proof in the pudding, if you will. So what we did was we took those crisis consumers, and what we saw is that they had a mortality rate of 26%. So in 3 years, the crisis consumers, their overall mortality rate was 78%. And even the heavy consumers, Medicare is spending somewhere around $42,000 a year on their care. Their mortality rate is 52%. So this is diabetes in the Medicare program that we're talking about. And this is how the program works, right? And I love all these comparative effectiveness studies, pay for performance, and all those kinds of programs. They're not really addressing what's actually happening to Medicare beneficiaries. And down at the bottom, we have those low consumers. Their mortality rate over the 3-year period is about 5%. Next slide. And so what's happening in the system, and here I'm showing you a model that we did for the period 2000 through 2006. So, and the point is, this has been going on for over a decade, right? The patterns haven't changed over in a decade. And so what's happening is, as those crisis consumers, because of their high mortality rate, die, right? The system, the crisis consumers and heavy consumers are repopulated by those low and light consumers because we're not reducing their risk. And so over time, the crisis and heavy consumers get replaced by light and low consumers. And again, it starts with everyone going to the hospital. Next slide. And so, you ask yourself the question, so why is that? Why aren't we intervening appropriately? And I point this out to you. Now, this is a letter that was written by the Congressional Budget Office to Nathan Deal, who was then a member of Congress, later became governor of Georgia. This was during the Obamacare discussion, and the idea back then was that if we provided preventative services, we could save those costs, those hospitalizations, and then we would have money to provide additional care for other people. And I want to read this really quickly to you, because this is the essence of what's going on and why we have an acute care system. What they say is a further consideration affecting the budgetary impact of proposals is that some types of preventative care may increase longevity. Of course, that effect reinforces the desirability of such care, but it could also add to federal spending in the long run. Social Security outlays rise and people live longer, and Medicare outlays may rise, because even if a preventative service lowers a beneficiary's risk of one illness, a longer lifespan allows for more time to incur other healthcare expenses associated with age. And the point is, we're not talking about preventative services like get your flu shot. This is also about how we manage diabetes in the Medicare program to reduce risk. Next slide. And so to give you sort of a graphic understanding, what the system is doing is managing financial risk. That's really what the conversation is always about in our healthcare system. We are talking about managing financial risk, but what we're not talking about is managing patient risk. We really don't have good metrics that talk about how we're managing patient risk in programs like Medicare and Medicaid. And so when you're talking about managing patient risk, you're talking about reducing acute events. You're talking about reducing hospitalizations. You're talking about reducing emergency room visits, disability, mortality, and improving the quality of life. And it's important to remember that financial risk and patient risk are very, very different things. And the argument certainly that we make at the National Minority Quality Forum is that we need to have that prime directive focused on reducing patient risk. Next slide. And we can create reports, and we can actually have community level intelligence about managing patient risk. This is not difficult work in terms of the analytics. We have the data to do that, and when we're talking about managing patient risk, we're not talking about a national disparities report or a report on adherence to specific guidelines. You're actually talking about how many people went to the hospital, how many people went to the emergency room, can we modify any of those rates? Next slide. And so what we're looking at here is, this is 2017. Remember, I was showing you back in 2000 what was going on with crisis and heavy consumers and all that. So I'm actually giving you the numbers now for 2017. It's the same model that existed in the year 2000. And mind you, we've had prescription drugs, we've had performance measures, value-based purchasing, value assessments, all of that stuff has been going on. But the basic fundamentals in terms of what's happening to Medicare fee-for-service beneficiaries hasn't changed in the last decade. And I'm showing you by breaking out, you can see the 3% crisis consumers with diabetes. You can see the low consumers down at the end. Next slide. And quickly, I'm just showing you, the hospitalization cost. And so I've broken it out by hospitalizations and ER visits. So you can see that really we're spending a lot of money in the system, is taking care of heavy and crisis consumers, and down at the bottom of the pyramid, with those light and low consumers, we're not really making the investment in. Next slide. And so at the end of the day, what the number is, 57% of all the dollars being spent to manage diabetes in the Medicare fee-for-service program is being spent on either emergency room visits or hospitalizations. Next slide. And so just want to give you a feel for, goes back to that study we did in 2000, but it hasn't changed very much. So if you were a crisis consumer in 2000, in 2001, you had a 58% chance of being hospitalized. And if you were hospitalized in 2002, you had a 62% chance. And by the time you got to 2006, you had an 89% chance of being hospitalized. Those crisis consumers in 2000 weren't hospitalized, but if they got hospitalized in 2015, their risk of hospitalization increased incrementally, so that by 2006, they had a 69% chance of being hospitalized if they were hospitalized in the prior year. And that's how the system works. And that's that acute care model that I'm talking about. And we have the data really and the technology now to do better than that. Next slide. So we built something called the Diabetes Index. All of those numbers that I've just showed you came out of that. You can actually go in and look at those rates by congressional district. So if you're going in to see a member of Congress, you can show them the distribution of how the money is being spent in his district, and the fact that really what we're doing is we're paying for hospital care. And you can see I just produced a map for you that showed where all of those crisis consumers around the country reside, and you can actually drill down and know who the providers are in the hospital, what pharmacy, what medications are on. I mean, all that knowledge is there, and it gives us the power really to intervene. Next slide. So I think there's a real call to action. I think we have to really focus our healthcare system on reducing patient risk. We can have these conversations about financial risk all day long, but they're not going to change the outcomes for patients unless we actually focus on it. And I'm using Medicare as an example, but we could talk about Medicaid, we could talk about commercial insurance. The focus is always on commercial risk. And so we want to take the data that we have and report out down at the community level. I mean, giving you national numbers, but you can actually go in at the community level and understand how diabetes is presenting in a community. And certainly we want to partner with community managers to use that data to really affect change. Thank you.
Thank you very much for that excellent presentation. And I think it's always startling for me, and I heard, we got a few comments during your talk that you're looking back 20 years, but really nothing's changing. And so I think what I took from your remarks was really that call to action for our own diabetes care and education specialist, armed with some of the data that you've presented today to really talk about patient risk, especially in the diabetes space, and how diabetes care and education specialists can better advocate for lowering those risks and what's entailed. And we appreciate you sharing the information about the data index, and I know many of our attendees will be eager to look at that. Are there any questions for Dr. Puckrin? We've got one. Do our health systems want us reducing emergency department visits and hospitalizations for people with diabetes if Medicare is spending 57% of the money for people with diabetes in my hospital and ED? I hear about Medicare break even, therefore I assume the money Medicare gives doesn't actually cover the cost.
That's really a great question. And the answer to that question really is, it's not what the healthcare system wants, it's what the beneficiary and patient want. we should be building our healthcare system for the beneficiary. It needs to be patient-centric and making sure that we're not elevating their risks when they come into the system because we're not aggressively providing them the care that they're looking for. And I think we can flip the model and become more patient-centric, particularly with diabetes. Diabetes in the Medicare program is one of the real cost drivers in the Medicare program. I think somewhere around 38% of all the dollars being spent in the Medicare program are being spent with people with an underlying condition of diabetes, and they go to the hospital a lot. So I think the way I would answer the question for you is that the focus has got to be on patients, and I think the system will follow if we reorient the system around patients. The hospitals, the providers, industry, they will reorient themselves and look to provide appropriate services to those patients.
Thank you. Another interesting question, what are your thoughts about how this can be addressed when we're talking about for-profit health systems?
It's at the end of the day, it's the same thing, isn't it? For-profit health care systems are really, the funds in those systems come from people, from the patients. It gets a little fuzzy because it comes to many times through the employer system, and it looks like the employer is doing it, but it's actually wages that people contribute to healthcare, and we need to make them responsive and more patient-centric, so that they're focused on reducing patient risk. That is, it's got to be the whole directive of the healthcare system. We can't have a healthcare system of any real merit if, when people go into the system, for whatever reason, it is elevating their risk for a poor health outcome, and certainly not telling them that there's a risk proposition here when you come in for care.
Thank you. And I know we've got another comment that Medicare beneficiaries must pay a copay for each specialist, which, when we're talking about diabetes, obviously that's a huge consideration. And that provides more barriers to that individualized care that we all seek to give, which I think is an important comment. And I know through our own policy, we're trying to eliminate some of the cost sharing, but in your experience, I wondered how much copays or cost sharing plays in some of the barriers.
So, the numbers look something like this. The average household income of a Medicare beneficiary is about $25,000 a year. When you look at the copays for a disease like diabetes, the out-of-pocket could be somewhere between $5,000 and $6,000 a year, because those hospitalizations and ER visits, they come with copays. And so if you got $25,000 a year and you got $5,000 to $6,000 in copays, do the math. I mean, that those are enormous challenges that people face.
And we know there's some really startling data about how the average out-of-pocket costs that people with diabetes pay, and it doesn't include medication. So we know that these costs are just add up exponentially. So
I would pay, and I think it's really important for your group to actually go in and look at the numbers for medications. It's not what you think it is. Yeah. I know there's a lot of noise out there about the cost of medications, particularly to Medicare beneficiaries. When we go in and we look at the numbers, the average cost for prescription drugs for a Medicare beneficiary is somewhere, with diabetes, is somewhere around $400 or $500 a year in out-of-pocket costs, and that includes, the insulin that everybody talks about. And the point is, that we're doing policy without the numbers, right? We're attacking problems without first getting a full understanding of what the numbers look like. And the reason why the prescription drug data looks the way it is, because a lot of them are subsidized. About 50% of people with diabetes in the Medicare program, they're out of pocket. There's about $2 or $3 because they're subsidized. So the numbers are not what people think they are. We try to drive solutions to problems that don't exist, and we ignore the real problems. And I would say the real problem is people are going to the hospital. So the point is, a person with diabetes in the Medicare program has a hospital and ER rate of 60%. 60% of every Medicare beneficiary with diabetes goes to the hospital. An African American with diabetes and ischemic heart disease has a 98% hospitalization rate. That's not a program, right? We're not attacking the program. We're off, having this fight about financial risk and not paying attention to what's actually happening to beneficiaries.
Excellent points, and people are echoing your points in some of the comments, and I think some references to new classes of medication that can add to the cost and importance of equitable access. A few questions about the data index itself. Oops, sorry, I advanced this slide. I know you can access the diabetes index through your website, which you've linked here. I can provide a more direct link for people. Miriam provided it. Thank you. She dropped the link right in the chat. Is there Medicaid data contained in the database?
We're just about to put Medicaid data in. It'll be probably another 30, 45 days, and we'll start putting Medicaid data in there.
Excellent, thank you. Yeah, and there are a few people commenting too, the need to put Medicare persons with diabetes on better medication and assist with reduced hospitalization. So really the whole system coming together, again, to address the patient risk and just improve outcomes, which I know people have been working to do for forever, but we hope that we can continue to move the needle on some of this. And then I just wanted to, you're getting a lot of kudos and thanks for your excellent slides. I just wanted to plug one more thing with the National Minority Quality Forum. For all of the healthcare providers on the line, this slide actually contains a link. Most Fridays, the National Minority Quality Forum hosts a webinar around lunchtime. Some of the topics, I think this week's topic is COVID-19 in children. Last week was about influenza immunizations, food security. There was one addressing obesity with a healthcare provider and an individual that was just excellent. I would encourage all of you to please visit this site, check out the list of events. It's really excellent. So ongoing resources from your team, and we thank you for your expertise and for your presentation. And this information is just so valuable as we go into our congressional meetings. So thank you.
I thank you for the time, and if we can be of help, certainly we can help those who are going in for congressional meetings by providing access to congressional level data so that you can talk to a member specifically about what's happening in their district.
That would be great. And I'll follow up with you to make sure that we have the right information to share with people as they go into their congressional meetings.
Sure.
Awesome. Thank you.
Thank you.
And we're getting close to our break, but I did want to just go back to a couple of comments. I know there is one question that is regarding the executive order on insulin pricing and FQHCs. Is Sheila or Jen still on the line?
Yes, I am, and I think Jen is as well.
Yes, I'm on.
Yeah, I just wanted to see, somebody had asked a question about, they approached one of their federally qualified health centers about the insulin pricing provisions in the executive order that President Trump signed this summer, and they were told that the action was illegal. Do you have any clarification or insight on that?
You know, I'm wondering if they still have to have the rule put out. There was a rule just released a couple of days ago, but I'd have to look into the comment directly. But, you know, the executive order directs them to do something, so there may be some regulatory hurdles they have to take before it's implemented. So that could be the reason.
Kate, why don't you, if you want to send me that note, Tiffany does a lot of work with the federally qualified clinics as well.
Okay.
Let us spend a little time figuring that out and get back to you.
Great, I will do that. And I know there was a big announcement made over the summer, but it really was tied to needing to implement certain policies. So I wonder if there's just a delay between signing an executive order and having the policy catch up.
Right, or if it's, as Jen suggests, something that needed some regulatory hurdles. But we can certainly follow up. So just send us the note and we'll do that.
I will, thank you. And then I think we've gone through most of the questions. A lot of them were for Dr. Puckrin's conversation. I had one, Joan Hill is asking about some of our congressional meetings, and do the individuals we're meeting with want info about their district, state, or nation? And if it's about their district, is it possible to break it down to that?
Yeah, absolutely. I mean, I tell this real world story from years ago when an issue was pending before the Congress having to do with CAFE standards, which are gasoline tank standards. And there was a large company that was very concerned about this issue, and they wanted to see a particular member. And they had trouble getting in until one day the member walked out of a hearing, and you know, his local Chrysler dealer was standing there, and you know, the senator said, "Gosh, you know, Joe, you know, great to see you. Why are you here?" And he said, "Well, Senator, we're really interested in and concerned about these CAFE standard discussions, and I want to talk to you about that. You know, I'm your car dealer from the state you're from, and let me introduce you to Lee Iacocca." The message there is it was about the local Chrysler dealer. It wasn't about Lee Iacocca. And so the more personal you can make it, which was always my experience when I was on the Hill, is I wanted to know what did it have to do with East Jesus, Kansas, because Dole cared about what the impact was on a particular community. So if you can talk about it in the terms of what it means to their community, what it means to the people in their local area or their state, that they hear that. National statistics are great, but it's compelling if it's a local story.
Excellent, well said, and so true. I think we talked earlier about collaboration and partnerships and how we all kind of work together with this advocacy message. And I think our role, Baker Donaldson's role, staff at ADCES, we can kind of talk on the national level in that context, but the benefit of having the individual provider talking to some of these offices is that you bring that local perspective. Here's what's happening in the district. Here's what's happening with your constituents. So there's something to be said for how critical that is. I also, Starlin has made a few really great comments. Just with regard to telehealth, we're now seeing commercial payers retreat from progress. People are stopped waiving telehealth copays, and so virtual care is costing more. I think this is something that's been on our radar for a while. Concerns are rising about this. Even as we transition to more permanent telehealth provisions under Medicare, right now there's a lot of waiving of copays and certain things, and when things transition, what's going to happen if people are paying more for virtual care? Certainly something to consider.
Kate, if I could just add one point to that, and it's a note that Tiffany made in her comments. there's clearly a great desire in continuing telehealth and making it available more readily to a broader population by a different set or additional set of providers. But there have been issues raised on the Hill, particularly in the House, but really both House and Senate. And that is continued questions around quality, around documentation, about the risks to patients. And so know that some of the hesitation or some of the concerns are more about being sure the patient is protected. And so those will continue to be issues. Again, while there's this tremendous push to continue to expand telehealth, making it readily available, not just in rural areas, but generally for a host of reasons, including people not being able to or choosing to leave their homes. And so know that a lot of pressure is there, but know there continue to be and are ongoing issues about let's be sure that it's the right thing for the right people under the right circumstances.
Absolutely. Thank you. And I think that's such important insight as we're trying to make sense of this new normal and this really dramatic expansion of care in such a short amount of time. So we are at 12:30 Central Time. We've just kind of wrapped up our question and answer. I don't like to stand between people and lunch, so I don't want to belabor this. We will meet again promptly at the top of the hour, so 29 minutes from now, which would be 1 o'clock Central Time, 2 o'clock Eastern, and 11 a.m. Pacific. I hope I got that right. But thank you to our presenters. Thank you for all of the wonderful discussions in the chat and the questions. You are welcome to leave your Zoom on and just come back, but we will see you in about 29 minutes at the top of the hour. Thank you. All right, hello everyone, we're back. It's just about 1 o'clock Central Time, and I'll give people a few minutes to get back on. And before we get started again, there was one question I was checking on with Baker Donaldson. Sheila said she'd follow up, so I'll be getting an answer to that hopefully soon. I wanted to respond to one question in the question and answer. It's about the 1135 waiver for telehealth. And I want to clarify the remark I made about the public health emergency being extended through October 23rd. Because I think there's some concern that the public health emergency is going to go away suddenly, and people have invested all sorts of time and effort into setting up these telehealth programs only to have it taken away. So the current public health emergency has been extended a few times. There's no indication that the Secretary of Health and Human Services isn't going to extend it again. As soon as we hear that anything to the contrary, we will get information out to members to help with the transition. But based on the information I've heard from Medicare officials, they are going to continue to, all indications show that they're going to continue to have a public health emergency for the time being. I also think October 23rd is right before the November 3rd election. I don't think you want to put the country into chaos, the healthcare system into chaos that close to the election. So if anything changes, I'll let you know, but that's a great question. Okay, so getting started for this afternoon. This is going to be our training for our congressional meetings. And Teresa Martin, who presented yesterday during our town hall, back by popular demand, is going to share some, just kind of summarize some of the information she talked about with some of the COVID-19 data. And we're going to hear from Lincoln Clapper, who is from Prime Advocacy. That is the firm that scheduled our congressional meetings. So he's going to tell us everything we need to know about the logistics of those meetings. Makes it a little easier when you're not trying to find the building or the room. So I think that's always helpful. So let's start. We always want to start with some of the basics. I know people are joining us with all different levels of expertise. So we're going to cover everything from how a bill becomes a law to different resources you can use to keep yourself in the loop. And I love to share this slide because I think it's, if you really spend a few minutes and drill down to it, it's informative, but from the outset, I think it's a little funny because it's so detailed and involved. I always say when you see this, easy, right? But there is a link here if you want to check it out. But what are we talking about? So when you're talking about how a bill becomes a law, you start with an idea. And we'll use the Expanding Access to DSMT Act to get started. It does look like a game board. Somebody made that comment. And we have an idea, we want to reduce barriers to Medicare beneficiaries accessing diabetes self-management training. So we've got to figure out the language. What do we want to change? Which part of the law do we want? And it could be us, it could be an organization, it could be another member of Congress, it could be another stakeholder. So you get the idea and you start to develop a draft of a bill. And then you've got to find somebody to support that. So you start to talk to legislators that maybe share your values with a particular issue, and you look for somebody in the legislature to take the lead. And this is the same for either the federal or state level. And then it's referred, then it's introduced. So you've got somebody to introduce your bill, you've got it written, then you introduce your bill and it's assigned a number. So when we're talking about the DSMT bill, it's HR 1840 and S 814. So when you're looking at S 814, that means it was the 814th bill introduced in the US Senate. The S indicates Senate. Then it's referred to a committee. So it's introduced. There are different committees of jurisdiction that oversee different topic areas. So in the Senate, anything related to Medicare typically goes to the to the Senate Finance Committee. On the House side, you usually see Medicare specific bills go to the House Ways and Means or Energy and Commerce committees. Once that committee reviews it, you then they'll send a report to the House or Senate. Hopefully the committee will review the legislation. Sometimes they call it a markup, where they have a hearing, they talk about it, they make changes. That's not always the case. Sometimes bills are fast-tracked. And then once it's referred to the full House or Senate, there's a vote. Whatever chamber votes, say it's the House, then it then has to go to the Senate. If there are any differences in the legislation, that usually has to be resolved through a conference committee or conference report to make sure that both chambers are in agreement. And then it's sent to the president. So sounds super easy. Check, 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 no problem. Well, gets a little challenging. But for those of you who want to dig a little bit more into the legislative process, go back to the Chutes and Ladders game that I showed you in the previous slide, and the I'm Only a Bill on Capitol Hill video. But that's the overview. So what we're doing with these congressional meetings is we're trying to stand out, and timing is everything. As Sheila and Jennifer and Tiffany talked about, we are almost to the end of the 116th Congress. Each session is a 2-year period. So when the 116th Congress ends on January 3rd, 2021, all of our work in that Congress is over. If a bill doesn't pass, it doesn't automatically carry over. So we've got to start over. And Tiffany spoke a little bit about that in her remarks. And the election is November 3rd, which we know and we covered. So really we're positioning ourselves to ideally pass the bill in this Congress, but also prepare for the next. And I think that's a lot of the reason why we chose this date for the Public Policy Forum and for our virtual Hill Days, because members of Congress are back home or wherever they are, because it's virtual, but they're doing some campaigning before the November 3rd election, and now is really the time to get on their radar. So this date is very strategic in our ask. And for your reference, in the 115th Congress, 443 laws were enacted out of about 1,300 bills. Currently in the 116th Congress, 158 laws were enacted out of 15,000 bills. Now, when I'm looking at that, those are staggering numbers, in my opinion, in terms of what ultimately gets passed. So I think it shows that we have our work cut out for us. But this is where hearing from constituents, sharing those personal stories, sharing those patient stories, and talking about the experience of the person with diabetes, whether that's you or whether that's somebody that you work with, is so important. Because it really differentiates yourself when you're talking about such a limited number of bills that are passed. So we're going to talk about a few pieces of key legislation for our congressional meetings. And some of these we'll be focusing on in our actual congressional meetings, Hill meetings. Some of them are just great to advocate for in general. And we do have an advocacy lens in which we view things, because we're not just going in to talk about the Expanding Access to DSMT Act. As you heard from Teresa yesterday, COVID-19 is a factor. Racial and ethnic health disparities, which were addressed this morning, are also factors. Access and affordability. The election guide that I referenced with some of those key provisions around pre-existing conditions and non-discrimination in plan design. That's the lens by which we're having this conversation. So we're going to try to frame up some information for you to help really make that compelling argument to your legislator. And diabetes care and education specialists have a story to tell. Please go into your meetings thinking that, because I know you're getting bombarded with facts and information and statistics, all of which are important. But I want you to take what you've learned today and really focus on what is the story that you're trying to tell. Why is this story and this policy important to you and the people with diabetes whom you serve or who you work with? You want to think of some personal stories that illustrate your point. I'm sure many of you have stories from your own practice or your own lives. Sometimes you can borrow a story. If there's a story that's particularly compelling, you can share the story of someone else. Obviously, you're not speaking on behalf of someone else, but if somebody makes a good point, I think it's always great to highlight that. Members of Congress and their staff do not always have a concept of the real life impact of a policy. And I think this is especially true with diabetes self-management training. I think they understand it in concept, but that's really where you come in to break down what it actually means. And as I said, we are discussing specific legislation, but in the larger context of what is happening in the country. And I think diabetes really fits into that conversation, because we know there's such an impact with the pandemic, with ethnic and racial health disparities and access issues. And so a few statistics that I think might be helpful going into your meetings and give you something to think about. We know that people with diabetes are not at increased for contracting COVID-19, but they do have a higher risk of severe illness and complications from the disease. We know that this is Medicare data. Communities of color are disproportionately affected by diabetes. And so COVID-19 compounded with additional diabetes burden adds to higher risk of infection, hospitalizations, and death. And I think we saw that from what Dr. Puckrin said in terms of really how are we looking at patient risk. We know that Black and Latino US residents were 3 times more likely than white people to become infected with COVID and twice as likely to die from the virus. So I think some of the things that we're trying to work towards are addressing some of those systematic flaws and inequities in our healthcare system. And the legislators must pay attention to some of these statistics and help to address some of these access issues. And then I want to call back on Teresa to share just a few of her slides from yesterday, because she had some really great information in there. So Teresa, if you want to go ahead and cover these next couple slides.
Absolutely. Can you see me? Sorry, I guess I had my camera off. Excellent. Yeah, thank you for inviting me back. This has been amazing. The speakers have been phenomenal. The data is outstanding. And I'm guessing that if this is someone's first time of going to meet with your members of Congress, that your head is probably spinning. And so my hope is these next few slides is just kind of share with you the way my brain's working around telling a story to my members of Congress, some of the data points that I've grabbed out of the information that we've heard. I'll have to update this slide with what we just heard from Dr. Puckrin. But if you think about one of the quotes I said yesterday was from a book called Stories That Stick. And it says, a good story closes the gap from the way things are to the way things could be. And I think this is a really good recipe for just thinking about how you go in to talk to anyone in Congress, is to say, these are the statistics, or this is the story, the way things are. This is what I'm bringing to you. This bill, whatever bill it might be, or whatever thing we're trying to get passed, is going to change that. And then this is how things will look after that bill is passed. It makes a beautiful story. It sticks. I think the first time I went to meet with members of Congress was 10 years ago. And I was so overwhelmed, and I went in so nervous, not knowing what the heck was going on, that I just turned into an encyclopedia. And I flipped out all this data at this person that was listening to me. I think it was Merkley in Oregon. And I think I almost caused him to pass out. He had no idea what I was talking about. And by the end of the story, my story that I threw at him, all he knew was that diabetes was really, really bad, and that there are these things called diabetes educators that might help. I didn't even get the point across as to what the bill was or what the bill might do. So if you take everything, grab a few key points, a few key stories, but bring it down to how things are, what the bill will do to fix some of the things that are the way they are, and how life will look like afterwards. So in my brain, I was kind of thinking about the statistics on this page. We've got 10,000 people every single day becoming eligible for Medicare. And that's going to happen over the next 20 years. If you look at those 10,000 people, 1 out of every 4 of those individuals have diabetes. That is a huge group of individuals entering this Medicare age group. And then if you look at the cost of treating them, and as we learned, not just from this slide, but from earlier from Dr. Puckrin, the majority of this 1 out of 3 to 4 Medicare dollars being spent on treating diabetes is going to things that are preventable. Emergency room visits, hospitalizations, all the things that diabetes educators really play a role in decreasing the risk for. So when we think of this story we want to tell, it's also compounded. Oh, can you go to the next slide? I think you have control. If you think about all those complications that we just heard about, COVID-19 is increasing that risk even more now than ever, and it creates that sense of urgency. So telling the story not just of Medicare, the numbers of dollars that are being spent on people living with diabetes, that these are preventable costs that we as diabetes educators play a role with, but we also know that people living with diabetes are at a much higher risk of having serious complications associated with diabetes. They also have an increased case fatality rate. But I think the most powerful study that I saw, that I shared yesterday, was where they looked at individuals that had been hospitalized with type 2 diabetes, and those that had A1Cs above 8 or blood sugars above 180 were 10 times more likely to die. They had 10 times a greater mortality rate than those that were in the hospital with better managed diabetes, closer to A1C of 7 or blood sugars less than 180. So that story is, to me, frightening. And we as diabetes educators have already shown that we decrease the risk for complications. We wouldn't be a covered service under Medicare if we haven't already shown ourselves to be effective providers to help lower risk and lower complications. So we're already recognized, but the problem is there's a ton of barriers that are preventing us access to Medicare patients. And that's what this bill is all about. It's trying to lower some of those barriers and allow members that have Medicare access to these very, very critical healthcare providers called diabetes care and education specialists. So I'll turn it back over to you, Kate.
Thank you. And in addition to those, and that's such a helpful way of thinking about it. And I hope that some of these statistics and some of this perspective will help you frame your own thinking about how you might want to approach this topic in your meetings. And then, as Teresa mentioned, some of the barriers to care, some more statistics to throw your way, but when we're looking at Medicare dollars, over 60% of diabetes care is paid for by government insurance. That's a huge number. We know from what's presented that complications are costly and life-threatening. And Medicare has had DSMT as a benefit since 1997. And we are so far into this, we know that DSMT lowers A1C, improves quality of life, reduces complications, enhances self-efficacy. I don't have to tell you the benefits of DSMT. This is where you really shine in terms of the perspective that you can offer. But as we're kind of talking about these conversations, I think the members of Congress and their staff need to know this as well. And despite all these benefits and everything that we know that's going on with COVID-19 and health disparities, still less than 5% of newly diagnosed beneficiaries eligible for this benefit are accessing this benefit under Medicare. 5% in the face of all that we know. So I think, and I'll turn it back to Teresa, this really, it drives home why we need to make the ask that we're making.
Yeah, and this was kind of taking all the stats and just basically turning it into very simple key statements. So if you support this bill, you will allow more people the ability to access and utilize evidence-based, life-saving diabetes self-management and treatment options. You'll decrease the risk of avoidable and costly complications. And this is probably where I would grab, I know Kate put this in as one of our resources. I don't know if you can see the little ADA stats on your state. This would be a great place to even ask them, do you know how much Oregon is spending on treating diabetes, mostly diabetes complications in Oregon? How much do we spend every year? They may not have that at their fingertips. In Oregon, we're a kind of a low populated state. We still spend $4 billion on treating diabetes every year, $4 billion. If we could use just a smidgen of that on the prevention of those problems, we have the chance of saving the state billions of dollars over the next 10 years, 20 years, 30 years. But more importantly, right now we can impact also how much we're spending this year. And we can do that through decreasing the number of those high-risk individuals that live in our state that are getting COVID and suffering serious complications from this disease. We as educators can reach out to one of that group of high-risk populations, which is those living with diabetes that are over 65, and help them get the necessary tools so they don't have to catch this disease, and if they do, how they can live healthier with it. So ending the bill has a potential just not only to save money, it can save lives, and it can help people with diabetes the chance to live a long, healthy life. Kabam! All right.
Done. Sign here, co-sponsor this bill. Thank you so much, Teresa. And I just feel like you've presented such great data that it's nice to synthesize it in this way as we're really going into those meetings and what are the key highlights that we can focus on. And Teresa mentioned the diabetes burden by state. That was in your pre-read materials. It's on the Public Policy Forum ADCES Connect page as a link. So feel free to check that out. I am working on getting access to the diabetes index that Dr. Puckrin referenced in his talk today, and I'll try to get that login to you if I can today, if not via email. And so let's get into the legislation that we're going to be talking about. Oh, the one question, would there be an index that tells the cost breakdown for diabetes in each state? So that is the diabetes data, the diabetes burden by state information that's in your pre-read materials. And I think we can drop it into the chat. Yep, we can drop that into the chat. Dr. Puckrin mentioned more specific information that you can drill down by district, and we're working to get some access to that database. Good question. So the Expanding Access to Diabetes Self-Management Training Act, HR 1840 S814, introduced by Senators Jean Shaheen and Susan Collins back March 2019, introduced in the House by Representatives Tom Reed and Diana DeGette, with 4 original co-sponsors. I do want to note this is bipartisan, bicameral legislation. So bicameral means House and Senate. There was a strong diabetes caucus in Congress, and each of these members has a tie to diabetes in some way. So this bill holds meaning for our leads. And just a reminder that the diabetes self-management training benefit is Medicare's version of DSMES. So if you get confused by the T, that's why. We currently have 68 co-sponsors on the House bill, 13 on the Senate's bill. Many co-sponsors were added during our advocacy work in our past public policy forum. And so what does this bill do? There was some information in your pre-read material, including an issue brief that we did provide to members of Congress in advance of your meetings. I'm not going to bet money that they read them, but they do have that information, and you can certainly use your issue brief to follow along in the meeting. And so there are different aspects of the bill. Based on some of the conversations that Tiffany has had with congressional offices, she mentioned that in her slide earlier, we focused on some of the really top priorities, things that offices seem to be most interested in. So I'm going to focus on these here. I know you're already getting a lot of information. So let's talk about the highlights. So number one, this bill would add more flexibility around the initial 10 hours of DSMT. Right now, we know that the initial 10 hours must be used in a 12 consecutive month period. And that's just really problematic when we're talking about Medicare beneficiaries with lives, with caregiver role, caretaker role, other health complications. It's just not feasible to have that time limit. And we always want the option for additional hours if they're needed. We know that diabetes self-management training and medical nutrition therapy cannot be provided on the same day currently, or can't be, is not covered when provided on the same day. So we're asking that this legislation allow those services to be provided and covered on the same day. We don't want to have Medicare beneficiaries having to go to multiple visits on different days for a similar service. So as I'm going through these, I want you to think, are there examples where somebody couldn't use their 10 hours and the time ran out, or they had to come back for multiple visits? Really try to draw in some of those personal stories as you're hearing some of the policy provisions. We also want to remove the cost sharing requirements. Starlin brought this up with regard to telehealth, but Medicare diabetes self-management training benefit is one of the few preventative benefits that requires a cost sharing provision. So we want to get rid of that. It's time, it's a barrier to care. We also want to expand the list of providers who can refer for this service. Right now, it's just the provider that's treating the person's diabetes. We want to make sure that if a person goes into an emergency department, the emergency department provider can then refer for DSMT. People may not be getting to a primary care provider or an endocrinologist for a referral. So we want to make sure that wherever that person is meeting, having a touch point with the healthcare system, that provider can then refer for this important service and get that care plan started. And then there's a provision to develop a demonstration project to look at how virtual DSMT can be provided. So that's another important aspect of the bill that is certainly speaking to the importance of virtual and digital care and very timely. So those are the four main provisions of the bill. I know some of you have done this before, but others haven't. I would encourage you to take a look at the issue brief and really put yourself into the policy and see where you can use some stories to illustrate that. And so just going through again, we know we want to expand coverage of DSMT to allow the first 10 hours to be available until fully utilized. We want DSMT and MNT to be covered and be reimbursed when provided on the same day. We want to remove DSMT from Medicare Part B cost sharing and deductible requirements, so removing all of these out-of-pocket costs for beneficiaries. And these slides I know I just reviewed, but you can use them for reference because it shows the current law and the proposed change. So we want to permit the physician and qualified non-physician practitioner managing an individual's diabetes to be able to order DSMT services. It includes emergency providers who I mentioned, podiatrists and others. This is an important provision. And then this virtual platform. So this is kind of the proposed changes and how you would approach this demonstration project. So there are different parts to consider. I think the main point is just that we want to explore what providing virtual DSMT would entail. So it's not a commitment to adding it for sure, but it's an ask that we look at this more closely as a health system. And so we have our legislation introduced. I mentioned we have 68 co-sponsors in the House and 13 on the Senate. Now that we have all this going, we must build our list of supporters. And so that's where I'm talking about co-sponsors. And a co-sponsor is simply a representative or a senator that adds their name as a supporter to a bill. You can view the current list of co-sponsors by visiting congress.gov. You can also visit our website where we have the co-sponsors. There's a link there. And if your member of Congress co-sponsored the legislation and you're meeting with that individual, you can check your congressional meeting schedule. I believe it will be updated as of Friday as the meetings are finalized, whether that person is a sponsor. I would urge you just to check the list to see if who you're meeting with is a sponsor, because that's going to change how you have a conversation. And so now let's talk about some of the telehealth proposals. I think this is another great piece of legislation to discuss in your congressional meetings and tying in some of those access challenges. Again, I covered this morning, but to reiterate, we know that temporary telehealth expansion during the pandemic provided for a lot of flexibility. So DSMT programs are now eligible to furnish DSMT via telehealth for the duration of the public health emergency. There's that audio only provision for DSMT. And as I mentioned when we got started, just to clarify, the current public health emergency is set to expire on October 23rd, 2020, but there is no indication that that's actually going to take place. The Secretary of the Department of Health and Human Services has extended that public health emergency a few times already. Medicare officials don't anticipate that the end is in sight. I think that would create a lot of chaos in the healthcare system right now. So anticipate that this will be renewed for at least another 3 months. But if there's any indication to the contrary, then we will certainly make our members aware of that. There's now both Congress and the administration are considering proposals to make these telehealth changes permanent. There's legislation in the House and the Senate. There's been a series of hearings, and there's some disagreement on how to proceed. Do we need to study some different things? Do we need to look at private payers for data? So I think Congress is really looking at approach. But many of the proposals include the same things. There's a general desire from members of Congress to expand the list of eligible providers. And they have to do that by permanently changing the statute. So it's Section 1834M of the Social Security Act, and that's why Congress is involved. CMS doesn't have the authority to do that on their own. They want to remove originating and geographic site requirements. And this means that during the pandemic, beneficiaries have been able to access telehealth from their homes, which has been great. But prior to that, Medicare telehealth only allowed Medicare beneficiaries to access telehealth from an originating site. So if you had, because really telehealth under Medicare is meant for more rural populations. So let's say you have a Medicare beneficiary getting a telehealth service. They would have to go to an originating site like a clinic or FQHC and receive the telehealth service there. So we really want to remove that burdensome requirement. We also want reimbursement parity. Services that are provided via telehealth should be paid at the same rate as in-person services. And then I think there's a real desire among members of Congress to collect some data to help inform future decision-making. And there is a letter with all of our telehealth asks on our Legislative Action Center that I referenced this morning. If you can't join us for our congressional meetings, or you don't feel like you have enough time in your meeting to discuss, feel free to send a letter or grab some talking points there. There's also an issue brief with more information. And the Connect for Health Act, I'm not going to be I don't think we'll cover these in our congressional meetings, but I do want you to be aware of this long-term proposal. As I said this morning, this predates the pandemic, so it does have some important provisions. We also have a letter for this piece of legislation available on our Legislative Action Center. And here are our list of telehealth asks. So as we're going into our congressional meetings, and we'll do a kind of a meeting outline in a next slide, but this is a long list. I'm not expecting people to just check off the list and regurgitate everything on the list. You may choose some of the priorities and then share the issue brief that has more detailed information as a leave behind. Like, you may want to go into your meeting, talk about telehealth, and say, we'd really like Congress to remove some of the geographic and originating site requirements. We want beneficiaries to be able to get services in their home. And then we also want to expand the list of telehealth providers. Could you include and consider eligible diabetes self-management training programs in that expansion? So I think there's a way to highlight on some of the key points without having to go through every single item, but these are here for your reference. And so let's talk about how to prepare for these congressional meetings. So we'll be discussing specifically the October 5th and 6th meetings, but these meetings can be applied to any meeting that you have. So I have your pre-read materials, what to expect in your congressional meetings, and a sample outline. There are instructions for accessing your slides. The Legislative Action Center has a lot of great resources. Our virtual public policy forum, ADCES Connect page, also has resources. If you've signed up for the forum, you can access this using your ADCES Connect login. And then there are all sorts of materials there. And then Lincoln is going to provide some information to you in terms of how to navigate the database. Okay. So next, so how do we prepare? So we already went through this. You want to start by reviewing the Expanding Access to DSMT Act and telehealth issue briefs. Start with that. Start by going through some of the data in the slides that talked about DSMT, that talked about COVID-19, all those issues that Teresa framed for you. And I want you to think about, as we already discussed, how some of these policies impact you or your clients personally. These are personal stories. What are the issues that are important for you? And you're going to start to create that narrative, which looks a little different for everybody. I think we can stick to a script to an extent, but each meeting is going to be a little different based on your priorities and the priorities for your legislator. You'll see when you access your meeting information that you may have other diabetes care and education specialists with you in the meeting. So if you can connect with them in advance, if you have any questions about doing that, please feel free to send me an email and I can make that connection. We also, one of the suggested pieces of information that Lincoln is going to cover is that get on the call a few minutes early to kind of coordinate who says what. I think Sheila touched on this point. Get to know your legislator. Do a little bit of research. Who are they? Are they a co-sponsor? I showed you where to find that information. Are they on a key committee, which we'll address in another slide? Did they go to your college? Do they live in your town? What personal information can you find about them in the most non-creepy way possible? Use our Legislative Action Center to find some information on legislators, and some of them you might know already, or you may be volunteering for their campaign. Feel free to tie that in, but it does help to give some thought to that in advance. And then we all covered this, and I'm working on the login for the diabetes index, but try to pull some state-specific information because I think that question might come up and you can use that information in the way that Teresa suggested in her comments. And remember, you are representing ADCES in these meetings, so I would just advise if you're likely going to be meeting with somebody who maybe isn't of your same political party or disagrees on an issue. So just be mindful that you are representing the organization and some of the issues that we're talking about here today. And just keep that in the back of your mind as you go forward. And there are some other issues. We talked about the election guide and some of the items like talking about protecting provisions for pre-existing conditions. Feel free to incorporate that, but just give some thought in terms of what you think makes the best sense for your particular meeting. And I did want to flag this information. Tiffany mentioned in her slides that we had been doing some very targeted outreach. We have specifically been trying to get Republican members of the Senate Finance Committee to sign on and support this legislation. And we have meetings with those on the screen so far. And I will follow up individually with you if you are in one of those meetings, just to help you with some talking points. Really, the rationale behind that is we want to get a score from the Congressional Budget Office. And we really think we need a key member of the Senate Finance Committee on the Republican side to help facilitate that request. We've got a lot of Democratic support, so we'd like to see that bolstered with some Republican support. And I will follow up offline. The asterisks, so Senator Grassley and Senator Daines, if anybody from Montana is on the line, we've already done a meeting with Senator Daines, but this meeting is, the Grassley and Daines meetings are with the senators themselves. So that's a pretty exciting meeting. And so what to expect in your meetings? These will be taking place by phone, which coming from a world of in-person meetings is such a different feeling. But the phone meetings work. I can tell you I've done quite a few phone meetings with congressional offices this summer. I know some of you have as well. Oh, hi, Marcy. She's from Montana and she'll be in the Daines meeting as well. That's great. The phone meetings are great. They just take a little bit more organizing. And so I'm going to go ahead and give you some tips that have worked personally for me. Sorry to be redundant here, but I think it just helps to say it again and again. Review your materials. If you can, coordinate with others in advance and dial in a few minutes before the call. Something that I find really helpful is ADCES Connect. You can connect with your colleagues. You can post on the Public Policy Forum page, say anybody going to this meeting, I can help connect people. So don't feel overwhelmed if you're not really sure who you're meeting with or you don't know the person in your meeting. Begin with introductions, chat about the district, understand any time constraints. So that goes something like this. I would also suggest if you know who you're going to be meeting with in terms of other DCES, figure out who's going to introduce themselves first. So when I do meetings with others, we usually have a game plan of if it's alphabetical or just figuring out in advance who's going to kick off the meeting and what the order of introductions is going to be. If you don't do that, it's fine. The meetings are small. It's not going to be a problem, but I am an organizer. I like to have everything laid out, so it does help to know who's going to say what. And chat about the district. I think it's a strange world that we're living in, and so I think it's really fine to just have a chat at the beginning. And I find it always helpful to say, I'm not sure how much time you have today. How long do we have you for, or how long do you have today to meet? That's helpful just to understand, and then just keep your eye on the clock. If the person says they have 15 minutes, be mindful of that. And then if the member of Congress is a supporter, make sure that you acknowledge them and thank them. If they are a supporter, you don't have to talk about the DSMT bill. You can provide an update saying, we appreciate your support. We appreciate your support, and we're still working to build support for this bill. So if there's anything that you can do to share with your colleagues, we'd appreciate it. So there's a way to work around it, but no need to get into the specifics if they're already a supporter. And then you're here because you're the expert. I think it's great to say, I'm not sure how much you know about diabetes care and education specialists. Let me tell you who we are, what we do. And I think that that's a really great way to bring that personal connection in there. Tie it to the district. I'm a diabetes care and education specialist at Chicago Hospital, and usually they'll perk up and be excited to hear from somebody from home. And this is a sample meeting outline that is in your pre-read materials. I think you can kind of consider it a checklist. We covered the first two issues, the introductions and the role of the diabetes care and education specialist. But something else that I think is helpful, that third bullet point, is how to frame the issue. So we're DCES, we're increasingly concerned about the tie between COVID-19 and diabetes, and we want to address the health disparities in our district. So we're here to talk to you about how we think you can help us remove some of the barriers to care. And that way is through the Expanding Access to Diabetes Self-Management Training Act and some of the permanent policies on the table to expand Medicare telehealth. And then you can provide some background on DSMES. What is it? I would caution against asking direct questions to the staffer or the member of Congress saying, do you know what DSMES is? A much better way, I think, to approach it is to say, I'm not sure if you're familiar, or you may already be familiar, but let me give you a little bit more background on DSMES. I know we use a lot of acronyms. So I think that's a really good way to make the staffer or the member of Congress feel at ease. Talk about DSMT refers to the Medicare benefit, who provides the service, and what is the purpose of the legislation. And this is a really great statement. We know the benefits of DSMT, but despite this, and despite everything that's been happening in the world, that advocacy lens, utilization is still low. So I think that's something that is a nice way to frame the issue and kind of keep that conversation going. And you want to discuss the legislation. So we're here to talk about the Expanding Access to DSMT Act. Despite all the benefits, it's an underutilized benefit. Just 5% of newly diagnosed beneficiaries utilize this benefit. Share personal stories. These are the key components of the bill. You can go through those one by one and add a personal story. It's great here if you want to divide, if there are other people that are going to be joining you for your meeting, if you each want to take one and determine that in advance. And then cost is always a factor. I know Dr. Puckrin talked about really emphasizing the patient risk rather than the financial. And I hope that you do that in sharing your personal stories and your perspectives. I can tell you members of Congress also want to know the financial piece. And we have a cost savings estimate that shows what we anticipate the savings will be if this legislation was enacted. And that is included in your pre-read materials as well. So and members of Congress have been provided that document in advance, though I'm not expecting them to reference it, but I think you'll find that when you access the database with your congressional meetings. And then the ask your legislator to sign on as a co-sponsor of the legislation. This is really important. This is why you're meeting. And then you can move on to the next issue, whether that's protecting pre-existing conditions or choosing a few of the telehealth services you'd like to see permanently expanded, referring to our issue brief and any other information there. We've said it a million times, but just want to reiterate, I can go have a congressional meeting. Tiffany and Jen and Sheila can have a congressional meeting. We can share facts and figures. We can represent the interests of the diabetes care and education specialists, but you tell the stories. You have those personal stories. You are the expert, and there is no substituting that expertise. So I know, again, there's a ton of information presented today, but really think about what you're bringing to the conversation. Nobody knows this issue better than you. If you don't know the answer to a question, you can always follow up or refer to extra materials. There's no problem. Stop periodically to see if there are questions with what you're saying. And if you don't know the answer, it is okay. You don't have to answer every question. A staffer might be thinking aloud and throw more of a process question at you. Just say you don't know and that you can follow up. And again, ask the member of Congress to sign on, thank the member of Congress or staff member for their time, offer to serve as a resource for any diabetes or healthcare related issues, and ask if there's anything that you can do. I know I mentioned earlier, the Connecticut coordinating body had a meeting last week and really talked about this relationship building aspect of what we do. It's not just a one and done. We're developing a relationship with some of these offices. So what can you do? Can you serve as a resource? Do you have any questions about diabetes? We're here to help. And I think that's an important thing to offer. And you can follow up over time. You don't always have to be going to a congressional office with an ask. And I think that's important to remember. Meeting follow-up. In a traditional meeting, you would send a follow-up email and say thank you. You'd be given a business card. To be honest, I'm not sure if you're going to have the contact information for the member or the staff member you're meeting with. So I think it's always fine to say, if there's any follow-up, would you feel comfortable providing your email address? And then you can follow up with the thank you. Sample text for an email thank you is included in your pre-read materials and on the Public Policy Forum site. So you can go ahead and pull that sample text and use that, modify it however you'd like. Again, I noted that if the staff member's email address is not provided, you can kindly ask them on the call if they'd be willing to share their email. There should be no problem with that. And then Lincoln will cover this in his presentation, but there is going to be a meeting notes section on the Advocacy Prime Schedule database, and you can provide feedback on that meeting. And if you're like me, sometimes you don't want to provide the meeting only in writing. You need some additional, you want to have a conversation about it. Although you might be tired of hearing my voice come Monday and Tuesday, but I have set up these congressional debrief calls. They're open calls. I'll be on the phone from 4 to 5 both nights in case anybody wants to talk about what they learned in their meeting. Others will be on the line. You can share information. If this does not work these times, feel free to reach out to me separately and we can talk offline or talk at another time. I just want you to know that I'm here as a resource, both as you prepare for your meetings and as you follow up from your meetings. So please make a note of these. I did add them to the Public Policy Forum page in ADCES Connect. They are under events, and so you can find that information there. So I've gone through a lot. I know that's kind of not to sound like a broken record today, but what are some of the common questions that we receive in our congressional meetings? So the first, Tiffany alluded to this in her talk. What is the cost of this legislation, or does it have a score? So you'll remember that a score is a reference to a cost estimate conducted by the Congressional Budget Office. This tells if a legislation costs the system money or if it saves the system money. And what's the answer? So you'll know from our previous conversation that we're trying to obtain a score. And as you can imagine, every bill that's going through Congress and that's trying to pass needs this economic analysis, this financial analysis. So that's why we're appealing to some of those Republican members of the Senate Finance Committee to elevate this to a level that gets some added attention. And so I think that's really important. It doesn't have a score yet, but we do have a cost estimate. The Diabetes Advocacy Alliance worked with a private firm to develop this analysis. It is provided in your pre-read materials, and so you can share that. You can share that reference during your meetings. And the average cost savings, according to our calculations, is about $1,300 per Medicare beneficiary each year, or $12,760 over 10 years. This legislation is estimated to save Medicare between $4.9 and $9.4 billion over 10 years. And the whole rationale behind the savings is that the more people are utilizing the benefit, the more you're reducing that risk. So you're seeing a reduction in hospitalizations, a reduction in emergency department visits, and that then yields a savings to the system. The Congressional Budget Office doesn't always calculate things in this way, but I think it does give us some framework to talk about. And so I addressed these. You can use these as talking points if you need to. The lower utilization of those types of services leads to lower cost overall. Again, we understand the cost, but what about the score? This legislation has not been scored by the CBO, but with your help, we'll have a score soon. Another common question, what are the benefits and evidence supporting DSMT? Is it effective? I don't have to tell this to you. You are truly the experts on this. But if you do get the question, feel free to talk through your perspective on the benefits and evidence around DSMT, DSMES. We know that these things are true. There's also a list of the studies, these studies here that demonstrate the benefits and effectiveness of DSMT. Those are also in your pre-read materials. We want everything in one place so you know where to go to get answers to your questions, because we're not in person and doing the same type of training that we normally would. So please put these in your resource bank and think about them. Everything's in the resource library on ADCS Connect. And so I know we have some questions, so I am going to go to some of the questions in the box. Let's start with, are you going to send us a list of what materials have been provided to our senators and congressmen? The only materials that have been provided have been the issue briefs and the cost savings analysis. So the telehealth issue brief and the expanding access to DSMT issue brief have been provided in advance. Just because something is provided in advance doesn't mean they necessarily have read it. So I would just offer that we do have the issue brief. You'd be happy to send it by email if they'd like it for reference, but they have been provided both issue briefs and the cost savings analysis. Another question, this is a great one. Is it appropriate to mention that you met with the office in the past year, or as follow-up to a request regarding the concerns, barriers to them from co-sponsoring? Yes, so absolutely. I know many of you will be meeting offices you met with in the past. Maybe they've signed on, maybe they haven't. It's perfectly fine to talk about your interactions with the office. Hi, Joe, it's nice to see you. We met, you maybe don't remember, but we met back in May 2019 when we were all meeting in person. Wasn't that a time? But we're happy to meet with you by phone. So feel free to reference past meetings. I would just keep in mind that they might not recall, but that's why we do this. We're developing the relationship. We're continuing to chip away at their understanding of the issue and get some recognition there. So great question. And again, the list of materials that were sent to the offices are the 2 issue briefs and the cost savings analysis, just to give them some perspective on what we were talking about. There's another question. or comment. Someone has shared with me the obesity is a common, serious, and costly disease document, which I think comes from cdc.gov, as well as some new adult obesity maps at cdc.gov. This might indicate the increased risk for poor outcomes with COVID. I think that's great. Lisa, if you want to go ahead and drop those resources in the chat, I think that would be great to share with people as another resource that they may consider. Thank you. Okay, so back to my question on how to close the deal. I've met in the past with the representative saying she'll take it under consideration versus I'll sign on. Should I bring a person with diabetes from her district that has received my care? Would that help? That's a good question. There are a lot of different reasons, and I think Teresa had this on one of her slides yesterday. What is preventing you from signing on? I don't know that I would bring a person that's not already scheduled to be in the meeting. I think maybe if you'd like to set up another meeting at a later date with a person from your district, that would be excellent. Or maybe you're not participating in the Hill Day and you're thinking long term and maybe you want to set up something in the future, I would do that. Members of Congress might not sign on for a number of different reasons. So I think in order to close the deal, bringing your perspective is important. Maybe asking, is there any information that you think you seem hesitant, or I know you've been reluctant to sign on in the past. Is there anything that I can do to clarify anything or answer any questions that may help you feel more comfortable with supporting this bill? It might be an issue of cost without having a CBO score. It might be an issue of any number of reasons. Maybe it's just their priority is oil drilling or something. So I think you can gently and respectfully get that information, but it really is about persistence. So to answer that question, I wouldn't bring any additional individual to the meeting that's not on the meeting list, but certainly I think that's an option for a future meeting. But great question. I might have missed this, but do we have a list of reps that have already signed on to the bill? Yes, so let me go back to an earlier slide. This will be in your meeting, in your schedule material that you're going to use to go in your meetings that Lincoln's going to cover in just a few minutes. But I'm going to go back a couple of slides. I cover this in a later slide too. Sorry. Okay, so here is where you can find the list of co-sponsors. You can go to congress.gov and drop in the bill number. You can visit our ADCES Expanding Access to DSMT page, or you can check your congressional meetings. And if you have any issues with finding that information, just let me know and I can help you identify whether your member of Congress is a supporter. But very good question, thank you. I don't want to belabor points, but I also think we're taking in so much information that I want to make sure that we're repeating things because it's new for a lot of people. Okay. So I think I've answered the questions in the question and answer section. I see there's been some discussion on the chat. Great, so I think a lot of these same points. Starlin has a great point saying you can ask permission to share some information. May I share some details about diabetes education? That's a great way to open up the conversation. Just really going back to that original point where if you're introducing new information, you don't want to say, do you know diabetes? But you don't want to be in that mode. So you want to be more, I'm not sure how familiar you are. Let me tell you a little bit about this, or may I share some information about diabetes education? I think that's a great way to put it. Thanks, Starlin. I think I covered these questions. The conference call numbers will be in a later slide, and they are also in the slide deck. So let me, in the interest of time, I will cover the conference call numbers at the end, but you can achieve them, you can access them in the slide deck. Starlin makes a great point. ADCS is updating our systematic review soon. Great point. Lisa has shared some of those CDC obesity documents that she referenced, which are really helpful, so thank you. And Kelly Antonori lent my tried and true approach, Googling both bills, absolutely great point. And then I'm going to take one more question before I see if Lincoln is on the line. I see he is. And so the last question is, if meeting directly with a legislator who is up for re-election, what are the chances he or she may ask for support? An issue if you don't support the person's re-election. This is a really excellent question, and I'm not actually sure how much this would come up. I think members of Congress do a pretty good job in keeping the campaign separate from their professional duties, although in this day and age, anything is possible. So I think you can kindly pivot and just say, oh, thank you so much. I've got my ADCES election guide, and I am reviewing all of the candidates right now. I so appreciate your meeting today and the information. Is there any place you'd suggest I go to learn more about your campaign? I think that's a way to handle it, where you can kind of deflect and without having to see whether you're or respond directly whether you're supporting a candidate or not. So feel free to defer and just say, I'm still making up my mind. I'd love to learn more about your campaign. Where can I go for that information? And I think they'd be more than happy to share it. I'm hoping though that they do keep that separate. But thank you for all of those really great questions. We'll have time at the end because I know this is a lot, but I want to introduce Lincoln Clapper, who is from Prime Advocacy, and he is going to, I have Lincoln's slides right here, talk about the logistics, how we look at that database. So Lincoln, do you want to go ahead and go through your slides? And I can advance the slides if you'd like.
Yep, that would be great. Thank you, Kate. Good afternoon, everyone. My name is Lincoln Clapper. I'm one of the directors here at Prime Advocacy. This will be, I believe, our third year working together, Kate, on this event. So this will be our first virtual event. So I wanted to spend a couple minutes here running through the logistics of how you all be able to access your schedules for next Monday and Tuesday. So the best way to do that is to use your laptop or desktop. You can use a tablet, but really the interface and the functionality of downloading the files that'll be associated with your schedules is really best served on your laptop or desktop. So you can access your schedule by going to the site listed here in blue, clients.primeadvocacy.com/attendee/login. And you'll know you got to the right site because there's a screenshot here to the left asking you for your email address. And so you won't need to create an account. You won't need to create a password. There will just be one field listed there. You'll type in the email that you registered for this event with and hit the blue continue button, and you'll be launched into your meetings. Now, as I mentioned earlier, this is we've been working on this event for several years now with this group, and so we store previous schedules as well. So once you get launched in, you may see a 2019 schedule or a 2018 schedule, but it'll be very clearly identified. So just select the 2020 schedule, and it'll launch you into your list of meetings for next week. Next slide, please. Now, once you are launched into the schedule, it's very self-explanatory. In the upper right-hand corner of each meeting will be the status of that meeting. Looking at your database right now, we are at 91 confirmed and 9 still pending. So the majority of the meetings are confirmed at this point. As you scroll down, the meetings are in chronological order. You may see a pending meeting at the bottom of your schedule, and that just means we're trying to tie up a couple of loose ends with that office. or we're waiting to hear back on something to get it finalized. But as those meetings do get confirmed over the next couple days, you'll see them slotted in there chronologically wherever it best fits your schedule. Next slide, please. Now, this is a 2-day event, so please pay close attention to the date listed at the top of each meeting. Like I mentioned, all your meetings are in chronological order, so you will see all of your October 5th meetings first, and then it will cut down into your October 6th meetings as you scroll down from meeting to meeting. So please pay close attention to the date listed on the top of each schedule so you're dialing in on the correct day. Next slide, please. Starting from top to bottom, you'll see the time listed. Now, in the beginning of doing these virtual events with a lot of our clients, the Hill was experiencing a lot of bandwidth issues. And so they made a move to start the majority of their meetings 5 minutes prior to the popular start times, like 11 or 11:30, 12, basically quarter of the hour times. This, by and large, has been fixed. I leave this bullet point in here just in case there are a few meetings that do have a unique start time like this at 10:55 to let you know that it's not a typo, that is actually the start time. Now, as I mentioned, this by and large has been dramatically fixed over the last 4 months. And looking at your database now, there are no meetings in your project that have these unique start times. So you will not need to worry about it. But again, I just like to leave this in here as a reminder, just in case we have to push something back 5 minutes or we have one of these late pending meetings get confirmed at a unique time, it's not a typo, and that is your start time. But by and large, all of your meetings start at normal quarter of the hour times, 11, 11:15, 11:30, 11:45, 12 p.m., etc. Next slide, please. One thing I forgot before I move on, sorry, is that all times that you see listed there are in Eastern time. That's probably the most important thing to keep in mind. We realize the majority of you are spread out across the country, but the time listed in your schedule are all Eastern time. So take some time over the next couple days and over the weekend to do some conversion and make sure you're dialing in at the appropriate time locally. Next slide, please. Below that, you'll see the office who you're meeting with. Simply will list the title and their name. Below that will be the meeting with column, and that will just show you who the meeting is actually with in that office. So whether you're speaking with staff, it'll just show their title and name. If you see the member of Congress's name listed there, that means you are actually speaking with the member of Congress. In the location field will be the information for your conference call. Very self-explanatory. You'll dial the number that you'll see listed. When prompted for the access code, it will launch you into the meeting. The software that we're using is called Start Meeting, and you will, as long as there's one person on the line, you'll be in the quote-unquote waiting room, I guess. But once that second person joins, then the meeting will be initiated, and you'll hear a ping, and you'll be launched into a conversation. But before that, you'll hear some elevator music, waiting for that second person to join. So if you're the only person in your meeting, once the staffer or the author or the member of Congress joins the call, then you will be able to speak. Or if there's more than one person in your group who is meeting with an office, once that second advocate joins with you, you'll be able to communicate with each other beforehand, before the meeting starts. Next slide, please. Below that, you'll just see some supplemental information about the member. It'll show their party, their state, their district. Very self-explanatory. Next slide, please. Below that is a team lead field. This is generally a field that we only use for very large clients where there's hundreds and hundreds of advocates. Looking through your database now, we are not utilizing this field, so you will not see anything listed there because your groups are so small. We have complete confidence in you that you'll be able to decide amongst yourself who's going to open up the conversation beforehand. Next slide, please. In the talking point section, this is mainly where the majority of the eyes go when advocates first log in. And so we put a couple of reminders there just to help keep you on track throughout the course of your meetings over the 2-day period. So again, reminder, all times are in Eastern time that you see. The meeting time listed that you see is the start time. And we're asking all our advocates to call in 5 minutes prior to that start time. That way, when the staff or the office joins, you're starting right on time. And also, if you have more than one advocate in your meeting, this allows you all to touch base beforehand to communicate on who's going to open up, talk about any concerns you all might have as a group before the meeting starts. So really important to do that as well. Make sure you're calling in 5 minutes prior to that start time. You'll see, I just finished uploading these the other day, so you'll see blue text here. In this example, you'll see the same type of blue text in your schedule. Those are talking points pages. So if they are hyperlinked with a PDF file, go ahead and click on each individual talking point to get the associated file with that particular talking point. It's very easy to download. It will create a separate window for you, so it won't log you out of your schedule. But you'll be able, this is live, so once you review your schedule after this presentation or later this weekend, you can download those files and start doing some prep for your meetings. The last talking point there, the scheduling or technical support, will be a number that you, a prime advocacy number that you can call if you're having any concerns at all, whether it's a scheduling concern, whether it's a technical issue, really anything at all. Go ahead and call that number. You'll get connected with somebody from our team who will be able to take care of any concerns. Next slide, please. Below that will be the additional attendees. As I mentioned earlier, this group is rather small, so your meeting sizes are rather small as a conclusion of that. So if you do not see any names here, that means you are the only person in that meeting. You will not see your name there because you're looking at your schedule. These are just the additional attendees who will be on the call with you. So again, if you do not see any names listed in that field, that means you are the only advocate for that meeting. Next slide, please. And last but not least, the meeting notes section. This is a great opportunity for you to leave feedback on how the meeting went. And this is going to be really critical to Kate and her team because we're going to be sending this to them after the event is over. So please be as thorough as possible. You can take shorthand notes. You can talk about, was the meeting positive? Was it negative? Did they ask for more resources? Did they ask to follow up? Anything at all. Just be as thorough as you can. There's no character limit, so you can really have at it. These are personalized meetings. Nobody else can read them except you and Kate and her team, of course, at the end of the day. But once you've finished typing out your notes, click the blue Save Notes button. The page will refresh, and you'll actually see your text in the box after you click Save Notes. That's how you know you saved it properly. Some advocates do experience a timed out issue. And what I mean by that is if you have your schedule open for more than 20 minutes and there's no activity, if you're not engaged with the actual page, the schedule will time itself out, sort of like a security issue. When you leave your bank account logged in too long, it will time itself out. So before you begin to type any notes, I strongly recommend that you refresh your page just to make sure it hasn't timed out. Because if you go to enter in any notes after the timed out session has ended, it will not save your notes properly. So make sure you refresh your page before you begin typing anything, just to make sure you're still logged in. Next slide, please. And this will be our last slide. This is basically just some broad overview points that I've already mentioned, but just the most important things to keep in mind. Please call in 5 minutes prior to each meeting, and the time listed that you see is your start time. All the times listed are in the Eastern time zone. If for some reason you have a busy tone, we've seen this with, it just kind of depends whether maybe you're in a bad spot, or Verizon or AT&T or Comcast are acting up that day. If for some reason you get a busy tone, just hang up and redial. You'll get punched through on that second or third try. If an office does not join your meeting within 10 minutes past the start time, go ahead and hang up and call Prime Advocacy. That help number is listed in the talking point section, and let us know. The last thing we would want is for you to hang on the line for 20, 30 minutes and have nobody join. Things come up. Capitol Hill is, they're made of people too, and they make mistakes, and sometimes they miss meetings. So we'd rather hear about it early on and try to get in touch with them on the back end and try to reschedule everything for you. That way, you're not just sitting there on the line and knowing nobody's going to join. All of these calls have been scheduled in 15-minute increments. Now, obviously, there's a chance they could go longer, but it's good just to remember that this is what has been requested. That way, when you're doing your preparation and your practice over the next couple days, you're prepared for a 15-minute meeting. Obviously, a huge bonus if it goes longer, but again, just good to know on the back end going into these. that this has been requested for a 15-minute block for your meeting. And last but not least, please leave as much feedback as possible in the meeting notes section. Really, really critical for Kate and her team to get this information from you after the event. That is essentially your schedule in a nutshell. We're looking forward, like I said, to next week. We've got over almost 100 meetings confirmed at this point. So I will turn it back over to Kate, and happy to take any questions if they're coming through. Kate.
Yeah, thanks, Lincoln. I appreciate that. And I think once people get into the system and start to play around, you'll find that it's very intuitive. Even I can use it, so I think that that's really helpful. Lincoln, one question. You mentioned the timeout issue when we're working with the meeting notes. Can they type up their notes in a Word document and then paste them in the Prime Advocacy meeting notes?
Yes, that is a great workaround if you're concerned about possibly getting timed out. Lots of advocates will open up a Word doc and sort of take their notes during the course of the meeting on that pad instead, and then click the refresh button on our page, and then if you're still logged in, you can easily copy and paste it into the module, save your notes, and you'll have your notes saved at that point. And at least there's a backup on your Word doc if there's any type of technical glitch.
Thank you. I think this question is probably more for me. Regarding the meeting notes, do you want them from everyone or just one per team or group meeting? It's fine if there's just one person who does the meeting notes. I don't need one from every person who attends. So that's a great question, Lorraine. Thanks for clarifying that. Another question, is there an easy way to invite other members to attend meetings with you? And so I'm going to start this one off. I know Lincoln and his team have scheduled meetings based on who the constituent is. I know congressional offices typically like to know who they're meeting with. So I wouldn't just forward the invitation or the phone number. If there is somebody who might be interested in joining, if you could contact me and we can set that up with Lincoln. Is that a fair perspective, Lincoln?
Yeah, absolutely, Kate. Yeah, if they could run that through you and then run that through us on the back end, that would be the best form of communication if there are certain special requests for other advocates to join other meetings.
Thank you. Yeah, I know that, especially in person, congressional offices do get a little overwhelmed if there are too many people in a meeting. So we want to make sure that we provide some transparency in who's going to be in the meeting. And then I just made a note that we have provided Lincoln with our issue briefs and talking points for you that will come up in that talking point section. So some of the materials that we've been using and talking about today are already in there. I don't see any other questions, but I'll give it one more second in case anybody has one final thought before we let Lincoln hop off the line. But I do, as people are thinking, I do want to raise one. We were talking about how do we approach sharing information about DSMES and other things. And I forget who we're talking to here. We have the excellent motivational interviewer, excuse me, offering some perspective. I know Starlin gave a great way to phrase that, and so has Jan. So another way to ask permission conversationally would be to simply ask, what have you heard about DSMES or diabetes? And then I'd like to briefly share some things about that with you if you don't mind. So that's a really excellent suggestion. Thank you. I love these because I learn something every time we do a training like this. What is Prime, Lincoln, this one is for you. What is Prime Advocacy's phone number or email in case we need to reach out about schedule or logistics? And that is in the database.
Yeah, so that will be listed in the talking point section. We're finalizing some assignments today and tomorrow. So by Friday, you should see that information going into the weekend. And if you have any concerns Friday or over the weekend, you can email and let us know. We'll also be available live all day Monday and all day Tuesday at that point too.
If you have a technical issue like my phone line isn't working or nobody's on the line, please reach out to Prime with that information. But if it's a question like, I want to add 2 people to my meeting, or this time doesn't work for me, please contact me with that information. And then we've got another question. Will we receive the list of senators, House members? Is that, so if you are signed up for congressional meetings, I provided everybody with a link, and Miriam, if you could drop in the instructions for accessing the congressional meetings in the chat, you can go ahead and log in with the email address that you registered for the event with, and then you'll be able to see the members of Congress who you're meeting with and see your schedule. So I hope I answered that question. And then I think those are, that is it. So a technical question goes to Prime. A question about adding to the schedule or changing the schedule comes to me, because I can see the whole database. And I know you have been very gracious in keeping your schedules open for scheduling on the 5th and 6th, and I know things change, but we are somewhat limited in shifting things around, so we may just have to proceed on.
Hey, one last thing I did want to mention. We were talking the other day about getting your co-sponsor list in there as well. I'm sure you've already probably covered that earlier in your policy discussions. So in the special notes field, if you want to go back maybe 2 slides, maybe let's see here.
Do you want me to go back?
Oh yeah, were you able to go back a couple slides? Sorry. Yeah, so right here above the talking point section, there's a special notes field, and so we'll be inputting in there if that member of Congress is a sponsor of S814 or HR 1840. That way you know going into that meeting if they're already a co-sponsor of that bill during your discussion. So that'll be updated here over the next couple days, but that will be live by Friday, and everybody will have that information available for their meetings next week.
Yes, thank you very much. That's so helpful. I think I appreciate you going through all these points, and everybody will have the slides for reference, but I do encourage everybody to log on when you can over the weekend and really go through and make sure you're understanding things, because I think that will help. Any other questions for Lincoln? I do want to note, I mean, this is brand new for us, but Lincoln has been doing this since the virtual meetings. I think you did your first in April or May, is that correct?
Yeah, yep, first week of April, yep.
So you're old hat at this, so we appreciate your guidance and troubleshooting all of the issues. So we thank you very much for that.
Yeah, absolutely. Let us know if you have any questions after this event, or after, if you're just seeing this recorded version now later in the week. Happy to answer them over the weekend.
Great, thank you so much. And you can also direct your questions to me if there's anything that you need. So thank you, Lincoln. Okay, so we're due for a break. Why don't we do like a quick 5-minute break? We'll come back at about 2:28. Is that too specific? Or we can say 2:30 on the dot, and then we'll start off with Jasmine Gonsalvo, who's going to do her update on the National Clinical Care Commission, and then think about any other questions you have. We'll have some time for Q&A, and we'll go through these Hill scenarios after Jasmine's presentation. These are a little bit more fun. So take 5, or more like 7, take a stretch and think of any questions, and then we'll follow up in just a few minutes. Thank you, everyone. Hi, Jasmine. We're just taking a quick 5-minute break.
Cool.
So we'll get started in 2 minutes. And do you want to share your screen?
Yeah. Oh, it says, can you make me a co-host?
Did you get the request?
Oh, maybe.
I think I gave you co-host permission.
You might have given me host.
Oh, well, if you want to take it from here.
I don't know. It's giving, when I click on share screen. Oh yeah, it sounds, or it looks like, because it's asking if I want to stop other screen sharing. So it'll let, yeah. Although I only have PDF slides, so it might look a little funny. It's not going to look as nice as like PowerPoint presentation. I didn't think about that. At least I don't think so.
I think that's okay.
I think it's going to have to be now.
Listening to me for the past hour and a half, so I think to hear from anybody except for me is going to be.
Okay, do you want me to start sharing? Do you want me to leave this up, or do you want me to put my slides on now?
No, you can put your slides on.
Okay, or maybe let me see. Yeah, it's going to be in a PDF. Weird.
Okay.
Okay, do you see them?
I see them.
Oh, good.
All right, I think we can go ahead and get started. We've done a extra. Oh, I'm trying to move your screen. Sorry. What is happening? So welcome back, everyone. I'm very excited to introduce Jasmine Gonzalvo, who is a woman who usually needs no introduction because I know many of you know her already, but she is coming to us in her capacity, which we talked about this morning, as a non-federal member of the National Clinical Care Commission. And so Jasmine is going to be reporting on some of the important work that the commission has been doing. And I just want to thank her for being here. And this is such excellent information and has such potential to change diabetes care at the federal level. So I'll turn it over to you, Jasmine.
Perfect. Thanks, Kate. Kate, can you hear me at least?
Yep, we can hear you. You sound great.
Perfect. Hi, everybody. My camera said I have 3 screens in front of me, so it might not look like I'm looking at you, but I'm doing my best. So hopefully it's not, it doesn't look like I'm looking off too weird. But I'm happy to give a brief introduction on the National Clinical Care Commission. If you tuned in to our meeting a couple of weeks ago on September 11th, this is going to be pretty boring because I'm giving you basically the same recap of what our draft recommendations are with regard to DSMES. And I would love to have a little bit of time for feedback because these are essentially our first round of draft recommendations. And for those of you who don't have a real good handle on what the National Clinical Care Commission is, it's essentially a group of 23 of us, and about half of us are federal members and then half of us are non-federal members. The federal agencies are FDA, CDC, VA, basically federal agencies that are relevant to diabetes. And then the non-federal representatives are largely physicians. So I'm representing 2 communities, primarily the diabetes care and education specialists and pharmacists as well. There's a nurse representative as well as a patient representative, and but by and large, the non-federal representatives are physicians. So I'm doing my best to represent our voice on the commission, but essentially we've been commissioned for a 3-year period to provide recommendations to federal level agencies to improve diabetes across federal agencies. And so we have a pretty big task that we've been assigned, and it's difficult. It's as hard as it sounds, if not harder. I actually was just on a call and had to leave that call to join this presentation, for a commission call to join this presentation. But so happy to be here and looking forward to maybe some questions and some feedback. I did not mean to do the spoiler alert. That's the end of my presentation. I'll skip to, okay. So our larger commission is divided into 3 main subcommittees: treatment and complications, prevention targeted population, and prevention general population. I sit on 2 of the subcommittees, treatment and complications, as well as prevention general population. Today, I'm really only going to focus on my work with the treatment and complications subcommittee because that's focused on DSMES, and I feel that it's most relevant to this crowd for obvious reasons. We have focus areas within each of the subcommittees related to social determinants of health, health equity, and research. Within our small group, our subcommittee, the treatment and complications subcommittee. So again, I don't mean to represent the entire commission. I really am bringing our draft recommendations specific to DSMES to the Public Policy Forum today, just because I feel like it's most relevant. But all of our information is publicly available. You can Google National Clinical Care Commission, and all of our notes should be posted there briefly if they're not already, and everything's publicly available, our public meetings and whatnot in our conversations. So I encourage you to go there if you want to see the full breadth of work that we're covering. But again, I'm focusing on DSMES today. Within our subcommittee of treatment and complications, we are focusing on DSMES, team-based care, diabetes technology, and virtual care. And the other subcommittee that there's so many committees and work groups. I'm also on the team-based care and the diabetes technology, but I'm the lead on the DSMES. And looking at our overarching recommendations, they relate to health equity and reduction of health disparities and optimizing individualized care. Essentially, one of our draft recommendations is suggesting that federal agencies review their health policies to look at how they create health disparities or could promote health equity. So that's kind of an overarching theme of one draft recommendation within our subcommittee. So specific to DSMES, and these are draft. These are draft, which is why we're totally open to comment, as well as, did I skip one again? I apologize. No, maybe I didn't. So we're open to comments. There are public comments periods available in between our commission meetings. So all of this is open to revision and suggestions for change. Our subcommittee has spoken a lot with individuals at ADCES, Leslie Kolb, Kate, and a lot of people, Jody Lavin-Tompkins, and people, representatives from ADA as well, to help inform some of these draft recommendations and revise. These have already actually had suggestions for revision even from this draft. So this is the health equity draft recommendation that I just referred to asking federal agencies to review new and revised policies or regulations involving the prevention, diagnosis, and treatment of diabetes for potential impacts on health equity and disparities. And looking at the health equity lens with all things related to diabetes. We have talked to a lot of people in informing our draft recommendations, and they're all listed here. Again, a broad representation of stakeholders in DSMES. Our first draft recommendation should look really familiar, especially coming off of the heels of Kate's previous presentation on the bills that bills that you'll be supporting. We essentially extracted the main tenets of those bills and have provided them as recommendations to the federal agencies to obviously support. So these are really pretty straightforward and again, probably familiar to you. Secondly, I think a lot of you are also familiar with the complexities of accreditation requirements for programs, accreditation or recommendation or recognition that are required and can be a source of frustration. The documentation and compliance and reporting, I know I'm preaching to the choir here. So the MACs appear to interpret DSMES claim criteria differently, and the data standards for documentation are an additional burden. So the recommendation we have here are to ease documentation requirements and improve consistency with claim review process across MACs, and to set data standards for EMRs to ensure uniformity. The national standards for DSMES are what govern accredited and recognized DSMES programs. Largely, these have been governed by the Medicare quality standards, which are cumbersome and a bit outdated. So our recommendation here is to create a task force with the authority to update the Medicare quality standards from 1997 that overall govern DSMT, and establish a process for ongoing timely review, updating, and revision with input from external stakeholders. And this is really to be able to have a more flexible model and framework for DSMES, so that meeting the standards for CMS can be less burdensome and difficult for programs. This one requires quite a bit more work, but I'm sure some of you are familiar with the Quality Innovation Network Quality Improvement Organization data, looking at, for example, community-based programs. So these aren't necessarily diabetes care and education specialists, but rather peer educators or community health workers. And so looking at community-based diabetes programs, the data that has come out of those. So we've drafted this recommendation here to develop a process to utilize QI and QIO data to generate CMS policies that support community-based diabetes education programs. And again, we know that this one requires additional work and massaging, but it's on our radar for a draft recommendation. Again, preaching to the choir, we know that DSMES is vastly underutilized, and looking to NIH, CDC, AHRQ, and VA, probably amongst other federal agencies, to prioritize funding for innovative research to explore factors that affect referrals to and patient uptake of DSMES, looking at patient, clinician, and systemic level barriers, quality measures and incentives, and patient-reported outcomes and perspectives. I wanted to leave a little bit of time for Q&A. Again, this is such a small percentage of the entire work of the commission, and so if you're wondering where the conversation is about closed loop or other technologies or pre-diabetes DPP, those are all the focus areas of some of the other subcommittees. And happy to answer questions related to that, especially if you want to email me or follow up with me. Happy to answer questions, but I wanted to take a couple of minutes. I think we have about 3 minutes for questions or discussion. Kate, is that right?
Yep. And to speak to what Jasmine is saying, the commission has just done an incredible job organizing this level of information. I mean, it's looking at diabetes policy across all of the federal programs, talking to stakeholders like ADCES and other organizations. I mean, the amount of data that you've collected to help inform your recommendations is really remarkable. So thank you for presenting this great work. Does anybody have any questions for Jasmine? I know it's a lot to think about, but I also think when we're talking about advocacy, going back from the very early slides, we talk about legislation and state level work, federal level legislation, regulatory action, and the commission has the authority to kind of bridge the divide in some of these areas, or bring this different perspective. So it's an incredibly useful entity. And so to have Jasmine here is really so important and such an honor to present this information. We've got a good question about timeline. Is there an end date in mind for the recommendations? And then what is the next action step? How will it change? Or when will the change take place next year?
Fantastic question. So the charge of our commission is really to present the recommendations at the end of our 3-year term. So we're in our second year. Our years are, I believe, begin and end in October. So we're coming up on the end of our second year. So by the end of our 3rd year, we will be presenting recommendations to HHS, and hopefully in a way that then produces action from the recommendations. And I think that that's a piece kind of the recommendations that we need to make sure that they have potential to make the impact, and that the agencies have the authority and the power and the resources to act on the recommendations, and it's not just an unfunded mandate. So it's a good question. At the end of the 3-year period, we will have finalized recommendations to HHS, and beyond that, it's in the hands of HHS to delegate the responsibilities to the different federal agencies.
Thank you, Jasmine. We got another question. We had a discussion yesterday, and this may not be within the commission's purview, because I think when Jasmine's talking about the quality standards, that's more in terms of DSMT accreditation and the national standards for DSMES. CMS set forth quality standards as kind of the baseline for all additional standards. But there was a discussion yesterday about the possibility of making an annual DSMT visit added as a quality measure versus an option to make it a mandatory requirement. Was this part of quality measures and incentives as part of your draft recommendation? So I think that quality measure might be more on the CMS quality side, part of MIPS, the merit-based incentive payment system, or something like that. But I'll let you provide your thoughts as well.
So I think this is a good question in terms of how our thought process has been. It goes back and forth between specific and general, right? And in some ways, when we get down to the nitty-gritty and specific, so for example, a very specific quality measure, if we're that specific, we feel sometimes when we get down to that level of specificity that we're putting a Band-Aid where we actually require a systemic overhaul. And so we go back and forth at the subcommittee level of, well, should we propose this Band-Aid, or is it more of a global recommendation that we need consistent, regular review and oversight? So I'm not answering your question, but I think that quality measures would all be considered and part of the discussion, although we do go back and forth in terms of what the final recommendation will look like, whether it's specific or broad.
Yeah, that's very helpful. And even on with other providers, I mean, I know we're talking, it's different if you're talking about like a quality standard as part of the national standards versus a quality measure like depression screening. So even the quality measures for other providers, there is some flexibility where providers can choose which measures they're reporting. So I think that may be something worthy of some additional conversation and kind of digging into what the best scenario would be, maybe not for the Clinical Care Commission, but for some of the diabetes organizations. Any other questions for Jasmine? One question was the commission that was established also to help reduce redundancies / improved collaboration across the federal agencies and organizations that provide diabetes services and resources.
Yes. So all things federal agencies and diabetes prevention is under our purview.
Yeah, no big deal.
No big deal. We'll just
a few things. I just remember the commission starting. I mean, I'm on the outside remembering it like living large. You're actually living it, thinking, I don't know how they're going to collect this information, and you've really done a great job. So kudos.
I think prioritization has been kind of one of our early wins, is that we're not trying to boil the ocean. We're trying to prioritize the most important issues.
Yeah, and it's been great to see the work of the commission throughout these past almost 2 full years. So congratulations on that great work, and thank you for providing us with an overview of the recommendations. It's such valuable information. Any last questions for Jasmine? Great. All right, well, thank you so much, Jasmine. We really appreciate it. And if any other questions come up, you can reach out to me and I can follow up with Jasmine, or I know many of you are in contact with her regularly. So thank you.
Thanks, Kate. It was so nice to be here, and so nice to, I looked at the participant list and I do know a lot of people listening. So it's so great to I don't actually see you, but it's so nice to be in your presence.
It's not a very interactive environment. I've spent much of the afternoon talking to myself in the mirror, essentially. So
great. Okay, thank you.
Bye.
Bye.
Thank you. Okay, so all right, so we are wrapping up. I'm going to go back in time. Bear with me. I know there was a different way to do this that's not subjecting you through. Okay. So I know we're kind of finishing up. We've just got a few minutes. I hope you will, oops, I'm going to, just 1 second, I'm sorry. I've gone a little bit too far back, so I'm going to catch us up. There we go. Okay. Just 1 more second. I'm sorry, everyone. As you've been sitting here thinking, any other questions that have come up about your Hill visits? I know everybody's going to want some time to go through the materials, and more questions may arise. Feel free to reach out at any time. I'm available. I'm here to help. I know Lincoln's provided some good resources. So, okay, let's try this 1 more time. All right. You can tell we had a near flawless Zoom day, and it's going to start acting up now, of course. All right, Hill scenarios. Indulge me on this a little bit. If you have, I just go ahead and shout out your answers in the chat. But I thought we could go through a few fun scenarios to see if we knew our stuff. So the first scenario is you're all set to meet with your member of Congress. You've even done your homework, but you find out you are meeting with a member of their staff. So what do? Reschedule the meeting, go through the motions, but assume the staffer doesn't know what they're doing. Take advantage of the meeting opportunity, connect with the staffer, and follow up with the office after the meeting. Throw in the towel on advocacy and take up knitting. C, you are correct. You might be meeting with the staffer, and that's perfectly fine. Staffers are the direct line to the member. They gather the information and shape policy making. They're the eyes and ears of the member of Congress. Scenario 2, and this is something that's come up a few times. You're meeting with the staffer, the meeting is engaged in the conversation. When you ask about their understanding of diabetes, they make a remark that reflects a lack of understanding of the disease, the experience of the person with diabetes, or a common misconception about the disease, especially with regard to type 2 diabetes. This isn't going to happen all the time, but you may get somebody that says diabetic, or I personally was in a meeting where the staffer said, oh, diabetes is the disease you give yourself. And as diabetes care and education specialists and people in the community, it's horrifying to hear a comment like that, but I think it's also an educational opportunity. So let's talk through how we might handle that. So what were you saying about taking up knitting? I'll take that option. I can tell you that was what I was thinking in that moment that I just referred to. Lecture the staffer on the error of their ways. This is unacceptable behavior. Make sure they don't make that mistake again. Alert their boss, post on social media, call your local newspaper. Use this as a teachable moment. Gently make the staffer aware of the appropriate terminology and bring more awareness to the issue. I'm sure you handle this type of scenario on a daily basis and are experts in navigating some of these difficult conversations. I see you're all shouting out D, that is correct. If you've got tips that you want to go ahead and drop in the chat on how to handle a situation like that, please feel free to do so. The individuals that I was with, this was a state meeting, pivoted nicely and said, let me share some information about what type 2 diabetes is, and here's some of the facts that might be helpful as you get a better understanding of this. The staffer says, this bill sounds great, but what does the CBO cost, or what is the score? We've gone through this a bunch of times. Now we're on the phone, you can fake static and hang up the line. I'm sorry that I just did that into the camera. You've had enough with me, I'm sure. Pretend you're in improv class, make up a number that sounds good. Explain that the legislation doesn't have a score, though our estimates suggest a significant savings over time, approximately $9.4 billion over 10 years. Refer to the cost savings analysis infographic. That's the material that you do have. And if you don't know the answer, don't be afraid to follow up. Follow up is just one more excuse to get in touch with the office and build that connection. So this is a tricky one, C and D. Don't panic if you're asked a tough question. There are many things that we don't know the answer to. It's fine to look it up. If you don't know, it's perfectly acceptable. Do your best. It's not going to be 100% perfect. And then closing out, I know we're getting very close to the end, and I can stay on if anybody has any additional questions, but just a reminder about how you can stay connected and utilize ADCES's resources that we've covered throughout the talk. You don't need to go to Washington to advocate. You can advocate year-round in your state, with your local officials, in your hospital system. There are just so many things. But before we go, I did want to make a note that Dr. Cochran did follow up with me about if people are interested in getting access to the diabetes index. I'm typing this into the chat right now to contact Taylor Stair at nmqf.org, Taylor, for access to the diabetes index. Just dropped that in now. It's behind a paywall, so you need some sort of access to get it. And Dr. Puckrin has graciously offered to access to some of our members who are participating in the Hill Day. So if you'd like that access, go ahead and reach out to Taylor in the chat. Important thing I didn't want to forget. Again, you don't have to go to Washington to advocate. We've got many engagement opportunities available with ADCES. We want you to subscribe to the advocacy forum on ADCES Connect. Please, if you learn nothing from today, just do that. That subscription will help you stay connected on what we're doing. You get email updates, great discussion, blogs, everything. Here's what it looks like. You get regular updates, discussion, all those great things. We also have our quarterly town hall meetings. Our next quarterly town hall is November 17th at 2 p.m. Eastern. Do not miss this one. If you attend any of our town halls, this is a really great one to attend. Information will be sent out through the forum. Other blogs, CNG, LNG, CB interaction, social media action alerts. Our Legislative Action Center is a great resource here. You can look up your members of Congress, your elections. Somebody yesterday mentioned they were going to send a letter to the editor of their newspaper. That is under media. You can go ahead and type a letter and send it that way. Key information about your legislators. This is a great resource. You can look at co-sponsors, who's co-sponsored the bill. This is another way to find out if your member is a co-sponsor. Our public policy forum page on ADCES Connect. I don't want to confuse people, but we do have a separate page just for attendees of this event so we can share resources for the event. We've also got a bunch of state resources, the Advocacy Priorities Survey linked here, our resource guide, once you identify the priorities, what you can do. Again, a reminder to how to access your co-sponsors. I've given you a few ways that you can do that. I hope you feel empowered to find that information. And so maybe just for fun after this, you look up the bill and see if your member of Congress is a co-sponsor. And then my contact information is here if you have any questions. And I'm just gonna go, and I wanted to show this slide one more time. It's the optional meeting debrief calls. Feel free to join us on either one of these calls. If they don't work, then you can go ahead and just call me directly or set up a time to talk via email. So we have covered a lot of information. There's a lot of resources here. Anything else? Lee is asking if we can send all the links from today's chat to attendees via email. Yes, we'll do that through the forum site, so you should get that via email. You've got Taylor's information, so you can reach out to Taylor from the National Minority Equality Forum directly. You can put the advocacy link on your ADCES CB page. That's a great suggestion, Diane, thank you. A good way to share information. I can stay on a few minutes if others have questions, but we are at the end of our program. I thank you all for joining us today. This was a brand new experience for us. It's different. I think anybody involved in advocacy is used to being in person and having that interaction. You've done such a great job communicating through chat and questions. So I really appreciate that. Just a reminder, all the materials are available. The slide deck is here. If you have technical questions related to your congressional meetings, do not contact me Monday and Tuesday because I'm not going to be able to handle it as quickly as Prime will. Contact Prime directly through the database. Any other questions, feel free to reach out. I'm happy to help you in the next couple of days, prep for meetings. But thank you all for being here. I appreciate everyone and all that you do. And here's to our first ever virtual public policy forum. Thank you and have a great day.